നാരായണ നേത്രാലയ ബാംഗ്ലൂരിലും LVPA ഹൈദരാബാദിലും ഇന്റേൺഷിപ്പ് കംപ്ലീറ്റ് ചെയ്തതിനു ശേഷം ബൈനോക്കുലർ വിഷൻ, അതുപോലെ തന്നെ പീഡിയാട്രിക് ഒപ്റ്റോമെട്രി, ന്യൂറോ ഒപ്റ്റോമെട്രി എന്നീ സബ്ജക്റ്റുകളിൽ ഫെലോഷിപ്പ് കംപ്ലീറ്റ് ചെയ്യുകയും അതിനുശേഷം ഒരു ലാസ്റ്റ് 5 years നാരായണ നേത്രാലയ ബാംഗ്ലൂരിൽ വർക്ക് ചെയ്തുകൊണ്ടിരിക്കുന്ന ആളാണ് മിസ്സസ് ആര്യ ശേഖർ. ആൻഡ് ഇന്ന് ഈ ഒരു സെഷൻ ഇന്നത്തെ ഈ ഒരു സെഷൻ സ്റ്റാർട്ട് ചെയ്യാൻ വേണ്ടി with immense pleasure I invite Mrs. Arya Shekhar to the stage.
Thank you for the sweet introduction, Ashwati. Good morning, everyone. So I am Arya Shekhar. So എൻ്റെ ഒരു ഇൻട്രൊഡക്ഷൻ ഓൾറെഡി എല്ലാവർക്കും കിട്ടിക്കാണെന്ന് അറിയാം. സോ ബേസിക്കലി ഞാൻ റെയ്ഹാൻ്റെ 13-16 ബാച്ച് സ്റ്റുഡൻ്റ് ആണ്. സോ ബേസിക്കലി സേയിങ് എ ബി ബാച്ച് സ്റ്റുഡൻറ്റ്. Yeah, so it's feeling like coming back home, and it's wonderful to see a lot of you people here. Looking forward to meet and talk and then interact and do workout. Okay? All ready? Yes. So I don't want to take this as a class or, just having conversation. I'm blabbering here, then go back home. You forget everything, I forget everything. This is not going to be like that, okay? So the conversation is... You want to say something? No, okay. So as per the request or as per the protocol, they have asked me to continue in English. But I'm absolutely okay to go with Malayalam whenever you are not understanding me, or if I'm totally actually a speedy person. So if you feel I'm talking too much and too fast, please let me know. Do not hesitate, okay? Yeah, so I just want to know who all are working here? Who are the staffs? Yeah, I just want to know about the count, that's it. And third year students of BSc? And diploma final years? All right, okay. No, I just want to know how I have to deal with this now. So today, okay, now my introduction already has been done by Ashwati, but still I'll just tell you, after I finished my bachelor's from here, I went for a clinical internship, finished from LVPA and Narayana Nethralaya as well as. So basically speaking, that was my real turning point. So-called an optometrist, I only knew I just have to do a refraction, give glasses, that's it. Trust me, people, you have a lot more work to do, and there is a big world open for all of you. Just don't sit and do the refraction and be a refractionist, Just being refraction is called a refractionist, never an optometrist. Got it? So, yeah. So, are you ready? Yes. So, we are starting. So, my topic is basically Tom and Jerry in binocular vision, but the Tom and Jerry is in a workshop basic. My talk will be designed binocular vision. So, how many people out there know about binocular vision? What is binocular vision? Whatever I say, it's fine. Yeah? So what is binocular vision? Okay. A lot of people are saying something I didn't understand. Fine. So before I start my presentation, I just want to give an acknowledgement. I have no financial statement or enclosure with anybody, any statements or anything. It's a free and entirely independent freelancing presentation over here. So how to design binocular vision? So my topics are going to include so many things that we start from anatomy, physiology, which are the basics of binocular vision. Then we'll be going for the complaints, which we will discuss about the symptoms and signs over here, and orthoptics. Basically, it's a process what you do binocular vision, then discussion, and finally we'll be talking about the management. So my session is not completely going to be just a talk. In between, whatever I discuss, we will have to practically do it. Okay, so I just want you all to be prepared, just not rush all that time, okay? Yeah. Why binocular vision? Why all of us have a binocular vision? At least human beings have binocular vision. Anybody knows? Why is it important? Anybody can stand up and say. Why we should have a binocular vision? You still can see, right? When you close your one eye, you still can see. Right? So why it is important when you open both eyes and see? Why is it important? Why is it important? Take it cool. Say. ക്ലാസ്സിൽ ചെന്ന് കമന്റ് ചെയ്യാൻ നല്ല രസമാണ്. ഞാനും കുറെ ചെയ്തതാ പണ്ട്. Okay, so see, just kidding, okay, don't take it hard. So namukku ella fun undaavum class li, that's okay. So basically, why binocular vision? Are we really seeing with our eyes? Is the eye is responsible for vision? No. We are not seeing with the eyes. We are actually using our brain. Yeah? So whoever has, for example, there was a patient who had come to my OPD. He was 6 years old. He looks absolutely normal. He speaks absolutely normal. No global developmental delay. No other histories related. But he cannot see anything. He looks normal. He reaches the objects very normally, but he cannot see. How does that happen? Because his brain doesn't process it. Yeah, when we talk about visual acuity, I think all of you over here must have read about visual acuity, right? Yeah, so what is visual acuity? It's a form vision. Yeah? So when you have a form vision, basically you're dealing with, sorry, I did not put it in the presentation, but before talking about this, we must know about two factors. One is ambient vision, second is focal vision. You know, until unless a person who does not have an ambient vision and a focal vision, you will never be able to see and process what you are already seeing in front of you. Okay? So what is ambient vision now? So when you have a visual acuity, you will capture the image, reach into the retina, pass the message to the brain, and then it will process. Then you will understand, okay, there is somebody sitting here, or that's an object, and that's the color, and that's a size. All right? But when you don't have an ambient vision, you will never understand what are you seeing. So, okay? So basically this ambient vision, focal vision is never mentioned in any textbook so far. Okay, until unless you don't really go and dig out of it, you will never find about these two terms. So whenever you have a visual acuity, it is always important to have an ambient vision, which is processing of what are you seeing. Now focal vision, where are you seeing it? I know there is a person who is sitting here. What's your good name?
Nabil.
So Nabil is sitting here. So I know Nabil is wearing a blue shirt and he's sitting just in front of me. But I don't know how far is he. Right? So I might think he must be very far, or I can think he's very close to me. Yeah? So understanding where the object is always focal vision. And these two are mainly done by brain. Okay? So now why binocular vision is important here? Because until unless the focal and ambient visions are not parallelly, simultaneously, not getting together, you will not have a proper utilized binocular vision. Again, why it is utilized binocular vision? Why? You know how much field we have utilized binocular vision? It's just 60 degree. Okay, so whatever the measurements going to the brain has to process it, make an estimation in your Panam's area. You must have heard about Panam's area, right? Yeah. So that awareness, until unless you don't have that awareness, you do not have an active binocular vision. So if you are not having an active binocular vision, you will never have any factors called fusion, stereopsis, convergence, and disparity. Okay, so now why binocular vision? Can anybody read that? Anyone of you? Just stand up and do. That's it. Easy. Yeah, you. Second one. Come on. Yeah. So what does it mean? What do you think? What does it mean?
We are seeing with the brain. Yes.
So we see with our brain. We see with our brain. Okay? Not. Yeah. So.
Brain is.
Thank you. So actually we have to use both together. So if you don't have a brain functional activity, you will not be able to see. If you don't have a good eye, you will still not be able to see. Okay? So that's what basically why binocular vision is important, because until unless you do not have a really good active binocular vision, whatever vision you have got, the residual vision, whatever you have got, is absolutely useless. So it's important here. Now, just I want to put it here. Whoever is having this fatigue, nausea, diseases, please try to avoid the next picture. It's actually a real anatomy of a preserved brain and eye. So this is how, it's a preserved brain and eye. This is how the brain and eye is connected. Okay, just for the normal formal information. Yeah, now let's talk about binocular vision. So here you can see a picture. There is a small bridge, very narrow bridge, and there is a very complicated rivalry background over that with multiple colors with the darker shades. Now, why binocular vision is important here in this picture? What do you think? What all factor has to contribute to see that picture here? First of all, are you able to understand the binocular vision from that background? Are you able to read it? Yes. So it's because of binocular vision basically, right? Yeah. And now, what else contributed that picture to keep there as a binocular vision example? So basically the picture you are viewing from the other end of this picture. Yeah, you are standing other end. And the second end is over there. Yeah? So if you do not have a proper binocular vision, you will not be able to understand the judge. You know, the depth, the judge of it. How much deep it is. And actually it is in the space, the bridge is in the space. And understanding it from the background, where you call SMP. Yeah? So SMP. So you have to understand it from a very complicated background with the hanging of the bridge. If these all together collocate each other, this is actually very simple to understand binocular vision. Again, anybody can read that? You please. Yeah. So basically it's very simple. Simultaneously, thank you. Simultaneously, when your both eyes are perceiving the objects and understanding three factors of it, then you are done with your binocular vision. Trust me, nobody has to understand or note down the definition. It is absolutely waste. Okay? Understand the concept, because nowhere in practical nobody comes and asks you what is the definition of binocular vision. Okay? Please understand this much. That's actually a state of an eye. Okay? It's an optical state of an eye where simultaneously both eyes has to be coordinated and collocated together to understand the object, where and what. Okay? This is what binocular vision. Now talking about the history, it's always interesting, I don't know, personally it's always interesting for me to dig about the history. So the binocular vision concept, basically to be specified, orthoptics has been started in the late 19th centuries, basically just after the Second World War. So there was no, a specific term or a specific statement, so-called binocular vision till that time, because nobody understood what was the importance of that. So after the Second World War, basically a lot of people got injured. So by second, even you can say that First World War also, there are a lot of people who have got injured, then many troubles were there. But the science was not so much improvised as like Second World War. So once it is over, there was a huge medical innovation happening around and people got wondered. Now when people have to survive with one eye, what all going to happen? So there comes a French ophthalmologist, Mr. Louis-Émile Javel. In his writings, he mentioned about binocular vision, and that's the birthday of binocular vision there. Okay? And it's actually happened in US, but he's actually a French ophthalmologist. Now you might have heard about Maddox rod. Yeah? So Miss Mary Maddox is the one who invented Maddox rod. So that's why it has named after her. So first orthoptist. Okay, now tell me, what is orthoptist? Who is orthoptist? What is orthoptics? So, small change. Yeah, thank you. Perfect. So, it's not about just the bone we talk. We'll talk about the muscles. Yeah? Yeah. So, perfect. Good try. Yeah? Yeah, such a good support. All right. So, what we were saying? Orthoptics. Orthoptics is a science or optics which is dealing with the binocular vision. Okay? Now, who is an orthoptist? So I'm an orthoptist actually. So basically what orthoptists do, whoever practices, an optometrist who practices the orthoptics and give the management of orthoptics trouble is called orthoptist. Okay? So she is the world's first orthoptist, Miss Mary Maddox, in early 1920s. Just for like it's always important to have some extra information, so please keep that noted. Yeah. So I do not like to, name it as an anatomy. So it's actually when you get a citizenship. When you get a citizenship. What age? Say loudly. 18. Yeah. So 18 years may we get maturation, so called, and government thinks that we are citizens. Yeah? See, so till that we are kids. So I before citizenship, which means when I is a baby. Okay? So when I is a baby and when I is infant, then toddler, then a kid. So that's what we are going to discuss here. So you can see, I just want to go through this anatomy. It's always there everywhere in your textbook, so don't stress on it. So when you check for a patient who comes to your OPD, how do you decide where to start the vision checkup? For example, a patient who had come of 22 years, how do you check the vision? Which method do you use? Which chart do you use? Snellen chart. Yeah, good. Sit. If there is a patient who is very illiterate and 65 years of age, what chart do you use? E-chart. Yeah. Please sit. Thank you. So there is a patient who is 8 years old. Yeah? What chart are you going to use? The red mafta. Yeah. It's 8 years old. Yeah. Snellen chart. Okay, yeah, good. And if the baby is 3 years old, green one, you. Yeah. Your eyes are beautiful, although. Picture chart. Yeah. So, So when it comes to a lesser age, we will know what is the status of the eye, right? So forget about the Snellen chart, whatever I asked. It's just to make you complicated. That's it. Basically, we should know where the eyes are right now. It's growing. Yeah, the eyes are kept growing till you become 15 to 18 years of age. You know the actual length is keep changing. So accordingly, the refractive status changes every time, every single day, to be specific. So we should know where the eyes are correctly. Let's say if a first standard student, you go and ask him, say about World War history, he will never be able to say that, right? So you should know what is the empowerment of that particular eye and then ask about it. So here it's important to understand the anatomy of eye. So when a baby gets birth, they have no fixation. Yeah, so an infant within 1 month of age, what exactly are you checking for? Let's say there is a prematurity kid has come to your OPD. See, one thing, I just want to tell you, we will not go anything theoretically because, just small story. Hello? Okay, sorry. Ellarum padichu kazhinjittu ellam kazhinjittu, this is because of the story. Okay, I will go back to that. Okay, your Anwar sir actually told me not to speak in Malayalam. Yeah, so I apologize him. That's okay. Yeah. So നമ്മൾ പഠിച്ചു കഴിഞ്ഞ് 4 വർഷമൊക്കെ പഠിച്ച് കഷ്ടപ്പെട്ട് 3 വർഷം കഷ്ടപ്പെട്ട് പഠിച്ച് നല്ല മാർക്കൊക്കെ വാങ്ങി ഭാരതിയാറിൽ പാസ്സാവാനൊക്കെ എളുപ്പമാണ്. എൻ്റെ ബാച്ച് അതായിരുന്നു. ബാക്കി യൂണിവേഴ്സിറ്റിയെ കുറിച്ച് എനിക്കറിയില്ല. സോ ഹയർ സ്കോർ ചെയ്യാൻ ബുദ്ധിമുട്ടായിരുന്നു നമുക്ക്. ബേസിക് ആയിട്ട് നല്ല നോളജ് ഉണ്ടാവും, പഠിക്കും, എല്ലാം മാക്സിമം നമ്മൾ കവർ ചെയ്യാൻ ശ്രമിക്കും. and you go to an internship and you have to stand like a Dumbo. You know nothing there. You know absolutely nothing there. Trust me guys, you are a rank holder, gold medalist. No use. When you go to, see, you have to study, that doesn't mean you should not study. Okay, naala poite parayarudhu okay, ma'am vannu tangana parannu nonu padikkathilla okay. So you have to study. You should know the basic. But why clinical internship is important? Because you should know how to use them. Trust me guys, nobody will be able to do until unless you do not study it as an application level. So whatever examples I'm going to tell you today is actually all my OPD experiences, probably the application level things, okay? So, yeah, coming back this. So what were we saying? So a patient who is coming. So when a patient will come, okay, let's get back to be serious. So when an infantile patient comes to you, what are you going to check for that patient who is less than 1 month old? What do you have to check there as an optometrist? So patient is not even fixating, right? Yeah, exactly. You should see the pupil reflex and you should also see the manic reflex. Why? Why not fixation? Why not perception? Why not PL? Why not? Yeah, because the patient does not have it. So basically at birth, the fixation reflex is poorly developed. It's still under development. Okay, so you might can ask here, I don't know how many people have got this question in the mind, but basically all other organs get developed by our gestations. You know, once you're in the tummy of mother, you automatically start developing it. Why not vision? Yeah, it needs light. Simple. Yeah, I mean, yeah, it's not necessary, but actually the point is that's great, yeah. The point is, you need light. You need light to go inside. So that's the reason it's not getting developed over there. Okay? So now, once the baby got birth to the earth, how many hours in a day, a small infantile, immediately after birth, how many hours the patient keeps eyes open? Anybody, any guess? ഒരു ദിവസം ഒരു ബേബി ജനിച്ചതിന് ശേഷം എത്ര മണിക്കൂർ കണ്ണ് തുറക്കുന്നുണ്ടെന്ന് അറിയാമോ? ടോട്ടൽ അവേഴ്സ്. ഇറ്റ്സ് ലെസ് ദാൻ ഹാഫ് ആൻ അവർ. 24 hourലെ ഇൻഫന്റൈൽ ഇമ്മീഡിയറ്റ് ബർത്ത് ആയിട്ടുള്ള കുട്ടി ലെസ് ദാൻ ഹാഫ് ആൻ അവർ ആണ് ഹോൾ 24 hourലെ കണ്ണ് ഓപ്പൺ ചെയ്യണത്. So it's quite natural to have a poor fixation. Now, patient, see, whenever you show some objects, let's say there is a baby who had come to you, like, give a sound. Patient will look at you. I mean, the baby will look at you. Yeah? So it's actually a sound reflex. Do not confuse this with a vision. This is not a vision. Okay? So, that's what. The poor fixation, our duration gradually increases as the days goes up. Okay? So randomly, actually it's a search moment. Because baby's eyes are getting open and the duration of the opened eye is increasing day by day. So obviously when there is no adequate vision, there will be a tendency of brain to understand what's going on around. Yeah? So that's what basically happens. Do not confuse any small kid thinking that, okay, the baby is looking at me probably because of the smell and sound and a new spatial awareness. Yeah, they do not have vision. So within month, as a, let's say you're making a sambar. You know, you can make sambar in different way, but still it's called a sambar. Yeah, in Bangalore we have something called chicken sambar. And when you go to, Tirupati, you will have a Thai sambar. You know, so it's actually when the contributions comes together, it's called as a sambar. But we are not sure that the contributions are adequate or not. So we are not supposed to say it as a vision. They have elements of vision, but yet to develop it. Okay? So, now what is pursuits movement? It's a slow movement of the eye. So basically, നമ്മുടെ extraocular muscles. Yeah. So pursuits moments. നമ്മുടെ കണ്ണ് ഡെവലപ്പ് ചെയ്യുന്ന സമയത്ത് ഫസ്റ്റ് നമുക്ക് വരുന്ന ആദ്യത്തെ ocular movement ആണ് pursuits movement. If a patient who does not develop a pursuit movement appropriately and appropriate time in adequate amount, the patient will not be ever able to use any extraocular modalities, okay, and the quality of vision. So, inability to carry out pursuits movements during the first few weeks of life, which is called what? Which is called what? Optomotor reflex. That's not vision. It's not the vision, it's optomotor reflex. So it is actually a postnatal event. So once the baby gets out of neonatal stage, that's where this develops. Okay, it's not immediately after birth, neither very late after birth. So 2 to 3 weeks may what is happening? 2 to 3 weeks, what's happening? Yeah. So patient starts following. Now, when a patient comes to a 1 year of age, 2 to 3 weeks of age, so you can check up. Can I take this? Thank you. So let's consider this as a torchlight. So you're going to use a torchlight. Again, just for a peripheral information, what color torchlight are you supposed to use in the OPD? Yellow. Why? Why not white? Okay, think about it. At the end of the session, everybody has to answer me this. So this yellow torchlight is there along with me without a restricted visual area. We cannot use a bigger torchlight and having a huge area that will suppress the patient's vision. Visual stimulations. Now, I can check the patient from right to left or up to down or inclined positions. So what is the accurate method? Suppose the patient is 1 month old. You have to check for what? Horizontal, exactly. Why do we do a horizontal one? Why not vertical? Yeah, because the aperture is more over in the horizontal area and the ocular movement is most of the time, how does it happen? So pursuits movements are actually less for the oscillatory movement. Like let's say the vertical oscillatory movements are very less for the pursuits. So since pursuits are the first ocular movement developing for a human being, it always takes a tendency of moving around, like right to left or left to right. It's because of the construction of the eye, anatomy of the eye specifically, because it's always having a bigger aperture over here. Okay? Yeah, thank you. That's what it is. Now 6 weeks to 6 months. Patients start follow the light binocularly. Here where we start our binocular vision. Okay, this is the exact point once the patient started using coordinated eye movement binocularly. That's where a binocular vision starts with. So coming to this point, I had to talk all these things. Now, first month to 6 months. Okay, first 1 to 6 months. Convergence, maturation happens, but still it is not developed. There is no convergence, okay? It's maturation. Why it's important? Because do not confuse convergence is developing by 6 months of age. It's absolutely wrong. It's a maturation. So when you make a sambar, you need to have a lot of vegetables. So you should start cutting them. And before cutting them, you should know what all you have to buy. So this buying part is happening here. Okay, this is called maturation time. So 1 to 6 months of age. Accommodation parallels to convergence by 6 months of age. Basically, നമ്മുടെ കണ്ണിലെ convergence ആണോ accommodation ആണോ ആദ്യം വരുന്നത്? Which one develops first? Convergence. Why? Who all say it's convergence? Please raise your hands. Whoever supports convergence, please raise your hands. I heard many of you saying, now you cannot keep down. So everybody say it's accommodation then? Okay, it's most of them like, enakku prashnamonnilla. Say, just guess it. Which one? Accommodation or convergence? Just simply please raise your hands, whoever supports convergence. Only one person? Yeah. Can you please stand up there? Now all of you please clap for her. Yeah. So basically convergence start developing first. Thank you so much. So convergence start developing first. Yeah, he said it. I asked. Whoever supports, nobody raised. Yeah. So convergence starts first. It's because it has lot to do with the muscles. And accommodation is, yes, it is related to the muscle as well as sensory part. You know, accommodation has a lot more to do with the sensory part. So sensory part of the body develops very slower than the motor part. So basically convergence starts first, but just immediately, it's like a twin birth. ഒരു ട്വിൻസ് ഉണ്ടാവുന്ന സമയത്ത് ഫസ്റ്റ് ട്വിനും സെക്കൻഡ് ട്വിനും തമ്മിൽ എത്രത്തോളം ഡിഫറൻസ് ഉണ്ടാവും? ഇറ്റ്സ് എ വെരി മൈന്യൂട്ട് ഡിഫറൻസ്. ഇറ്റ്സ് സെയിം. Okay, it's actually parallel together, but there will be always a difference. Convergence starts first and then come to the accommodation. So, accommodation and convergence, maturation time is 1 to 6 months. Yeah. Now, what is regional disparity? Why is it important? You have to tell me because it's all you have read about regional disparity. What is regional disparity? Anyone, please. Now don't look down. Tell me what is regional disparity. What is regional disparity? Why is it important? Tell me. Yes, it's somewhat correct. Yeah, thank you. So regional disparity has a lot to do with your development of stereopsis and convergence. So until unless you do not have a developed retinal disparity, you will not have a stereopsis or a convergence. Okay? So retinal disparity in one as she said, to understand an object, very simple. To understand an object, you should really have a retinal rivalry or retinal disparity, which contribute to have a binocular vision later age. So, stereo acuity. What is stereo acuity? What is stereopsis? Any one of you? The pink one just behind you. Depth perception. So, what is stereo acuity? Stereopsis is depth perception. So, stereo acuity? Good, thank you. Sit, sir. So, stereo acuity is the minimum vision acuity or sense of the vision to understand the stereopsis. Okay, it's a sense of the vision to understand the stereopsis. Very simple. So, until unless you do not develop a sense of vision to understand the stereopsis, you will not be able to understand the depth perception. Okay? So, stereopsis between the age of 6 to 3 years. Perfect. Now, actually, stereopsis is not an easy process to, comply. It is very complex. Okay? So, here you have a stereo acuity starting from 3 years to 6 months to 3 years. It's actually very basic of it. Stereopsis is a very complex thing. Just imagine you have something on air. You should understand the background. You should understand the object. You should understand how far it is and how long it is hanging. And you should have that visual perception really good. Okay, so it's actually a complex self. Okay? That itself is a very complexity. So it does not develop within 1 stage or 2 stage or 3 stage. Basically, stereopsis itself is a very big vast area. Unluckily, we do not have a specified grades as we say about binocular vision. But just a rough estimation, we can say start developing a stereo acuity first, then stereo awareness, then stereopsis. Okay, so these are the things. Stereo acuity starts from 6 to 3 years of age. This is just a starting. Now this has to gradually improve as the ages goes. Now why it is gradually improving as per the ages? What could be the reason? We know that anatomically the eyes are developing, the maturation time has to be taken, then until unless the vision is not going to be, or the factors are not going to be absolutely normal. We know all these factors. But The stereopsis has a specific reason it's developing very slowly. Anyone? Why? See, even convergence, accommodation, everything takes time. Everything gradually improves. But stereopsis has a specific reason to do this. You know, convergence and accommodation just have to have an anatomical structure to be improved and well settled, then it's going to be activated. But stereopsis does not activate like that. Yeah, brain development, yes, that contributes, but well, there is something really important. Think about a child. First, what they do? Do they come and start walking around you? No, they lay down. No, they'll be in a one position. And then they'll start rolling over. Then they start crawling. Then they start sitting. And then they start walking. Why kids keep unbalanced walking always, initially? It's because the vestibular stimulation has to be activated. Yeah? So just forget about vestibular, it's very complex. Anyway, it's just for information I'm passing you. Why they have a tendency, or when it's a smaller kid, just immediately started walking, they'll not come and suddenly grab the object. It takes some time for them to understand it. It's because they are still developing the depth perception. ഒരു കുട്ടി ജനിച്ചു കഴിഞ്ഞാൽ മാസ്ക് ഇട്ട് നന്നായി ഉറങ്ങുന്നുണ്ടല്ലേ? ഓക്കെ, സോ ഒരു കുട്ടി ജനിച്ചു കഴിഞ്ഞാൽ നമ്മൾ എന്താ ചെയ്യണമെന്ന് വെച്ചാൽ ആദ്യം കിടത്തുകയാണ്. സോ ആ കുട്ടിക്ക് സ്റ്റീരിയോപ്സിസ് യൂസ് ചെയ്യേണ്ട ആവശ്യമില്ല. സ്പൂൺ വരെ പേഷ്യൻറ്റ് നമ്മൾ ഫീഡ് ചെയ്ത് കൊടുക്കുന്നുണ്ട്. ഒരു പെർട്ടിക്കുലർ ഏജ് കഴിഞ്ഞാൽ നമ്മൾ സ്പൂൺ കൊണ്ട് ചെല്ലുന്ന സമയത്ത് ബേബി വിൽ ഓപ്പൺ ദ മൗത്ത് ഓട്ടോമാറ്റിക്കലി. ഇറ്റ്സ് ബിക്കോസ് ദ പേഷ്യൻറ്റ് ഈസ് അണ്ടർസ്റ്റാൻഡിങ് ദർ ഈസ് സംതിങ് കമ്മിങ് ടുവാർഡ്സ് എ കിഡ്. This is where the stereopsis start developing externally. These are the clues. So whenever you see an object, like baby is coming to your OPD and then complaining of something, you can actually go through all these histories. Just ask around them where the patient is opening the mouth, or when you will get the particular plates will be there. Like recently now, like whenever a kid get birth itself, they'll have a specific things for them. So they'll understand it and they'll start grabbing. Even though they'll be looking at the TV, they'll be like grabbing the food plates. Yeah, excuse me. So this is what it is. So basically, the need of stereopsis is slower for us. So until unless we don't stand and then walk, we do not have to have a proper stereopsis. When you have to have a proper stereopsis, because you have to reach to that. Let's say I have to slap him, I should have to go and slap him. Let's say I'm sleeping in some place, why do I have to bother about it? No, right? Sorry, I'm not going to slap you, okay? Yeah. മനസ്സിലായില്ല? ശരി. Okay, so gradual improvement of stereo acuity starts at the age of 9 years. Now sensitive period, which means ഇത് ഭയങ്കര ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള സ്റ്റേജാണ് നമ്മുടെ ഈ ഡെവലപ്പിംഗ് എന്നാണ് സെൻസിറ്റീവ് പീരീഡ് എന്ന് പറഞ്ഞാൽ ആ പീരീഡിൽ അക്യുറേറ്റ് ആയിട്ട് വിഷൻ ഇമ്പ്രൂവ് ആയിട്ടില്ല എങ്കിൽ, ഓർ ദിസ് ഫാക്ടേഴ്സ് ഡു നോട്ട് ഇമ്പ്രൂവ് an appropriate manner, then developing them in the later age is very tough. Okay, so this is a very, very sensitive period which has to be monitored really well. Being an optometrist, I don't know, many of you must be mothers by this time, but I'm not asking about that, but ഒരു മദറിനെ അത് അന്വേഷിച്ച് ചെയ്യേണ്ടതായിട്ടുള്ള കാര്യമില്ല, we will not know. But being an optometrist, especially when you deal with the kid, or when you deal with the binocular vision history, you should actually go through all these things. Whether the sensitive period was taken care very nicely or not. Let's say a patient, okay, who is coming to her OPD and saying that she is not able to appreciate the things, or she's going and bumping on it, but then when you check the visual field, it's normal. So actually you can start asking them all this about. So this sensitive period is specifically what time? 4 months. Peaks is 2 years. സോ യൂഷ്വലി ഞാനൊരു വിഷൻ തെറാപ്പിസ്റ്റ് ആയതുകൊണ്ട് തന്നെ നമ്മൾ എല്ലാം പറയുന്ന ഒരു കോമൺ കാര്യമാണ്, ഇഫ് ഇറ്റ്സ് വിത്തിൻ 2 years, വി ഗ്യാരണ്ടി യു. വൈ? Because when you start making chapati, how do you do that mold? You have to make the dough. Yeah? The dough, if you keep for some time, it's become stiffer. Right? And if, let's say, you might have to go for some work and come back, by the time it's become totally hardened. Now you have to make it looser. Whatever you do, you put it in an air fry, oven, hot water, oil, anything. It will never ever come back to the older soft dough. Okay, this is the reason. Because the sensitive period or the peak period, the optimal period of eye brain development is from 4 years to 2 years. Understood? Yeah. Oh, sorry, 4 months, sorry. So well developed by 4 years of age and slowly declines to keys. Okay, now, കണ്ണിൻ്റെ കാര്യത്തിൽ എല്ലാം ഇങ്ങനെയാണ്. ഒരു പെർട്ടിക്കുലർ ഏജ് വരെ ഭയങ്കര ഹൈ ഡെവലപ്മെൻ്റ് ആയിരിക്കും. ഇറ്റ് വിൽ ബി ഇൻ ദ പീക്ക് ആൻഡ് സഡൻലി ഇറ്റ് ഹാസ് ടു റെസിസ്റ്റ്. ഫോർ എക്സാമ്പിൾ, ഒരു ബേബി ജനിക്കുന്ന സമയത്ത് ദിൽ ആക്ച്വലി ഹാവ് ഓൾമോസ്റ്റ് 6 to 7 ഡയപ്റ്റർ ഓഫ് ഹൈപ്പർമെട്രോപ്പിയ, റൈറ്റ്? യാ. സോ അത് ഗ്രാജുവലി ഡിക്രീസ് ചെയ്യും. യാ. ആൻഡ് വൺ അറ്റ് എ പോയിന്റ് ഇറ്റ്സ് ഗോയിങ് ടു ബി 0. Might not be 0 also. Like, let's say I have 0.25, it doesn't matter at all onto my acuity. So, and then it start reducing. So this is always the technique of eye. Always the technique of eye. Take about accommodation, take about convergence, take about stereopsis, take about anything, any optical factor of the eye. It is always start developing from birth. It will go till a high peak and then again it will reduce it. Like, let's say your hair is also same thing. One particular age you will have the black one and then it goes to the gray one. Yeah, but it's a later stage. It's in the, you have to travel a lot to reach there. But eyes are not like that. They start aging very earlier. Okay? Yeah, so I think you all understood now. So basically, from 4 months to 2 years is the peakest time of the eye development. It's a sensitive part of the eye development. Now talking about physiology, you all have seen this picture in your textbooks, right? So what is Panam's area, what is horopter, diplopia, confusion, monovision, double vision, everything, right? The one with the blue, I don't know, please, no, just in front of you. Yeah. Your good name? Shruti. Jyotika. Yeah. Jyotika, can you just tell me what is horopter? I'm not asking you any question. Please share your knowledge. That's it. Yeah. Tell me what is horopter?
Corresponding points in a join area to area relationship.
Thank you, Jyotika. So horopter is a corresponding points joining dome shape to a particular, imaginary substance. So Panam's fusional area. Why it's important to have a Panam's fusional area and horopter? Are they real actually? Are they subjective or objective? Do they really persist? These all are imaginary perceptions. Okay? So I just don't want to go around this. So ningalku ariyalo Panam's fusional area. What is Panam's fusional area? Do you know what is Panam's fusional area? No. So why did you nod your head? Please somebody help him to understand what is Panam's fusional area. What's your good name?
Irshad.
Please stand up, Irshad. And who is going to explain him what is Panam's area? Stand up straight. Yeah. Don't make me call every time. It's waste my time a lot. Even yours. Who wants to explain him? Irshad, നിനക്ക് ആരും പറഞ്ഞാലും ഉദ്ദേശിക്കുന്നില്ല തോന്നുന്നുണ്ട്. എന്താ ചെയ്യാ? Just one of you please stand and then explain. Jyotika, explain him. One is Panam's area. അടുത്തിരിക്കുന്ന ആളുടെ പേരെന്താ? Gopika. Okay, I called Jyotika, not Gopika. See, this is not a competition. Okay, we're not in exam hall. We're not in a Vaive hall. It's just about sharing the knowledge. If it's wrong or right, doesn't matter.
Corresponding points in a join ചെയ്യിക്കുന്നതാണ്. പിന്നെ ഏരിയ ടു ഏരിയ റിലേഷൻഷിപ്പാണ്. ഡിപ്ലോപ്പി ഇല്ലാണ്ട് ആ ഒരു ഏരിയ ആണത്.
All right. Why don't one of you please come and sit here? It looks very congested. So be comfortable and free sitting. You have a lot of space around you. Okay. So Irshad, Panam's fusional area എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഞാൻ നിന്നെ നോക്കുമ്പോൾ നിന്നെ മാത്രമല്ല ഞാൻ കാണുന്നത്. I can say a lot of objects even though I'm not looking at them. Yeah? So that awareness, that spatial awareness, everything is still single for me. So basically ഐയുടെ ഒപ്റ്റിക്സിൻ്റെ ഒരു പ്രിൻസിപ്പിൾ അനുസരിച്ച് ഞാൻ നിന്നെ നോക്കുമ്പോൾ ഞാൻ നിന്നെയാണ് നോക്കിക്കൊണ്ടിരിക്കുന്നത്. I have all my visions on you. But still I can see all the surroundings single. This is called Panam's area. That particular area is called Panam's area. Now what is horopter? She explained just now. Intervalne I'll break തരും. അപ്പോൾ 100 times എഴുതിയിട്ട് പോരെ കേട്ടോ. Sorry. So വെറുതെ പറഞ്ഞാൽ ഞാൻ ഏതാണെന്ന് പോകേണ്ടത് വായിച്ചു നോക്കിയാൽ മതി. So when we talk about physiology, so we already finished about anatomy, how does it work, what does it work. Now when you talk about the physiology has, so first basic understanding itre illu, Panam's area and then horopter. And then talking about physiology, first you have to always discuss the grades of binocular vision. Tell me what is the first grade of binocular vision? Exactly. So we all got used to do this. എവിടെ നോക്കിയാലും whenever you will see this picture, a cage and a bird and sitting inside, and you have to say this is SMP. Please, I'm also fed up of that. So just, I don't know how do you people account this. What is this? Full jar soda. ആരൊക്കെ കുടിച്ചിട്ടുണ്ട്? Yummy. Oh, വലിയ പുള്ളിയാണ് കേട്ടോ. No good. So full jar soda. ഇവിടെ എവിടെയാണ് SMP ഉള്ളത്? Forget about the hands. അല്ല, കുറച്ച് കട്ട് ചെയ്തപ്പോൾ കറക്റ്റ് വന്നിട്ടില്ല. ഹാൻഡ്സ് മറന്നേക്കും. ഇവിടെ എവിടെയാണ് SMP ഉള്ളത്? യാ. സോ ഒരു ഫുൾ ജാർ സോഡയിലെ ഒരു ഗ്ലാസ് എടുത്ത് ഗ്ലാസ്സിൽ സോഡ ഒഴിച്ച് ദെൻ യുവർ മിക്സ്ചർ യു ഹാവ് ടു പുട്ട് ഇൻസൈഡ് ദാറ്റ് സോഡ. യാ. സോ അതാണ് SMP. ഇത്രയും മനസ്സിലാക്കിയാൽ മതി. എനിക്കറിയാം നിങ്ങൾ you already have read about SMP, you might have by hearted, you might have scored the toppers in binocular vision. You will forget it. Okay? And that's normal. So just remember our full jar soda. Okay? So that's what SMP is. ഒരു സ്പേസിലോട്ട് വേറൊരു ഒബ്ജക്റ്റിനെ ഇംപ്ലിറ്റ് ചെയ്യാം. That's what actually SMP all about. That's it. So grade 1. Now what is grade 2? Fusion. സോ ഫ്യൂഷൻ എന്താണ് നമ്മൾ കണ്ടിട്ടുള്ള എക്സാമ്പിൾ? ഒരു റാബിറ്റ് ഉണ്ടാവും, ഒരു ക്യാരറ്റ് ഉണ്ടാവും, ഒരു റാബിറ്റ് ഉണ്ടാവും, ഒരു ഫ്ലവർ ഉണ്ടാവും, അല്ലെങ്കിൽ എന്തുണ്ടാവും? ട്രെയിൻ ഉണ്ടാവും. യാ. സോ ബേസിക്കലി സിൻസ് ഇറ്റ്സ് വാലന്റൈൻസ് ഡേ വെരി ക്ലോസ് ടു us, I put this picture. Now where is fusion over here? A man with a flower instead of a rabbit with a flower. That's it. Okay. So a man with a flower. വാലന്റൈൻസ് ഡേ ആണ്, അതുകൊണ്ട് ഇട്ടതാണ്. എന്താ ചിരിക്കണേ? ഓക്കെ, ഇർഷാദിനെന്തോ ചിരി വരുന്നു പിക്ചർ കണ്ടിട്ട്. ഐ തിങ്ക് ഹീ ഈസ് വെയറിംഗ് ഡ്രസ്, വെൽ മാനേർഡ്. ഐ ഡോണ്ട് നോ വൈ ഈസ് ഫീലിംഗ് ലവ്. അതെ, നൈസ്, ഗുഡ്. ഓക്കെ, സോ വെർ ഈസ് ഫ്യൂഷൻ ഹിയർ? So the man is holding the flower. Yeah? So both has to be perceived in both the eyes in different images. Yeah? Same object, different images, fusing in the brain, perceiving this. Okay? So that's about grade 2. Now grade 3. Stereopsis. Stereopsis, what is stereopsis? Three-dimensional view, correct. Somebody can explain me, what is three-dimensional view? Why not 2D? So what is 2D and 3D, 4D? What is the difference? Okay, can you hold this? Can you hold this? This is 3D. Yes, this is 3D. When I asked him to hold it, he could actually catch it very well. To understand the depth of the object passing in a space. ഒരു സ്പേസിലുള്ള ഒരു ഒബ്ജക്റ്റിനെ മനസ്സിലാക്കുക. ദാറ്റ്സ് ഇറ്റ്, 3D. സോ യു ക്യാൻ സീ ദിസ് പിക്ചർ. ഈ പിക്ചറിലെ can you imitate this one? All of you just hold the hands like that. like this. You have to hold it like this. Now, both hands, yeah, like this. Now close one eye and see the image. Close other eye and see the image. Yeah, so you're seeing actually two different things. Two different images. Yeah, but of same object. നിങ്ങളുടെ കൈ തന്നെയാണ് കാണുന്നത്, നിങ്ങളുടെ കൈ നിങ്ങൾ മൂവ് ചെയ്യുന്നില്ല. പക്ഷേ ആദ്യത്തെ പിക്ചറിൽ നിങ്ങൾ കാണുന്നത് ഡൊമിനൻ്റ് ഐ മസ്റ്റ് ബി സീയിങ് എ ക്രോസ്ഡ് ഇമേജ്. യു വിൽ സീ ദിസ് വൺ ഫസ്റ്റ്. വെൻ യു ക്ലോസ് ദി അതർ ഐ യു വിൽ സീ ദിസ് വൺ മോർ ക്ലിയർ. യാ, ക്ലാരിറ്റി ഡിഫറൻസ് ഉണ്ട്. പൊസിഷൻ ഓഫ് ദിസ് ഒബ്ജക്റ്റ് ഇസ് ഡിഫറെൻറ്റ്. യാ, ദി ഇമേജ് യു ആർ പെർസീവിങ് ഇസ് ഡിഫറെൻറ്റ് ബട്ട് ദ ഒബ്ജക്റ്റ് ഇസ് സെയിം. ദാറ്റ്സ് എ ഡിഫറൻസ്. That is what stereopsis is. Everybody understood? So next time ആരെങ്കിലും വന്നിട്ട് എന്താണ് stereopsis എന്ന് ചോദിച്ചു കഴിഞ്ഞാൽ just ask them to do this and understand themselves. Don't try to explain anybody. Huh? Now retinal correspondence. What are the retinal correspondence? Normal retinal correspondence and abnormal retinal correspondence. Yeah, I'm not going to the science of this. Normal retinal correspondence are what? So it's very simple, okay? When there is an object in front of you, you're looking through the both eyes, and then the point which is lying on the right eye will be corresponding to the left eye. That's it, normal retinal correspondence. Abnormal one will be corresponding, the other will not be corresponding each other. No, they are not corresponding each other actually. Here, yeah. Now, you know what is this picture about? There is a man. Forget about the halos. Yeah. So you must understood what mode may I have done that. So forget about that. Just tell me what is in his face. His both eyes are closed. You have to observe the image very well. Okay, his both eyes are closed, first thing. Second thing, yeah, so the halos represent he does not have any sensation actually. Yeah, and third thing, there is a third eye on the forehead. What does that third eye has to do here? In retinal correspondence, in binocular vision physiology, what this third eye do? What this third eye do? No. It's called cyclopean eyes, binoculars. So subjective equivalent is actually imaginary one. Okay. So whenever you perceive or process two images of two different objects, talking about all the grades, NRC, ARC, everything. After all, these are, see, except RC retinal correspondence, everything is an imaginary one. So all the informations you pass through this and will be processed in one particular eye, which is an imaginary one, is called a cyclopean eye or binoculars. Why this eye is important? എനിക്കറിയില്ല, നമ്മൾ ഹിന്ദുവിൽ പറയും ഭഗവാൻ ശിവന് മൂന്നാമത്തെ കണ്ണുണ്ടെന്ന്. നമ്മൾ തൽക്കാലം ഭഗവാൻ ശിവൻ അല്ലാത്തതുകൊണ്ട് വാട്ട് ഈസ് ദ യൂസ് ഓഫ് ഇറ്റ്? What is the use of it? Yeah, it's a sensory part. After your optics has done a lot of things, there should be something which has to sense that optics of your eyes. Yeah, so that imaginary sense of that eye is called a cyclopean eye. It's actually corresponding subjectives of both the eyes, physical eye. Now we are actually being serious about our topic. Now, binocular vision. When a person has to have a proper binocular vision, what all are required for that particular person? Let's say you have to get a golden visa. You have criteria to do that, right? You should have criteria to do that. Yeah? Same thing. When you need to have a binocular vision, what are the criteria you have to pass through? What are the prerequisites of that? Please read it loudly, all of you. ഇപ്പോൾ കുറച്ച് പേരെങ്കിലും ഉറക്കത്തുനിന്നൊക്കെ ഉണർന്നു കാണുമെന്ന് വിചാരിക്കണു ഞാൻ. സോ പ്രീ റിക്വയർട്ടീസ് ഓഫ് ബൈനോക്കുലർ വിഷൻ. if a person has to have a normal binocular vision, either eye should have good visual acuity. You cannot have, you cannot expect a person who is having 6 by 36 and 6 by 6 in one other eye, respectively right and left eye, to have a proper binocular vision or perform like a normal person who walks around and do a routine activities. Yeah? So it has to have a good visual acuity. Even though you have developed all these anatomical factor, physiological factor, we blabbered a lot about it, forget. When it comes to visual acuity, if you have developed all these things, still binocular vision will not come to activation. Alright? Yeah. So, proper foveal fixation. A person who is having an eccentric fixation can have binocular vision or not. A person with an eccentric fixation. Say yes or no. Whoever says no, please raise their hands. Yeah, raise the hands. Raise the hands. Yeah, good. Yeah, so the rest of the people say it's yes. They will have binocular vision. Is it so? What is eccentric fixation? One will be at fovea, another will be extrafoveal area. Yeah? So will this person will have foveal fixation, binocular vision? No. Yeah. But still patient will have AHP, right? AHP. A person who is having eccentric fixation will have an AHP, which means the patient is not corresponding to the visual axis of the focal point. So patient will not have a binocular vision. Yeah. So nodal point matters only when you do refraction, not in binocular vision. Yeah? Okay. So normal RC. What is RC? Yeah. So it's very non. Visual field of both eyes should overlap to large extent. If at all you have a very restricted visual field due to any other pathological reason, you will not have binocular vision. So what is the field of binocular vision? (60°). Who all says 60°? Who all says 120°? 60°, please raise your hands. Binocular field of view. 120°. Yeah, perfect. So this is what. So basically what 60°, I don't know, maybe you guys have got confused with that 60°. It's an active state of binocular vision. Okay? It's not binocular vision field, it's 120° always. Okay? It has to have a large extension. Let's say you have a Panam's area and it's very restricted and you will not be able to make a proper fusion over there using the horopter. So what you have to do, you have to have a wild field of binocular vision which has to be extended largely over. Now what is next? Size of the image, shape, color, intensity. Whatever both eyes are perceiving the images, these 4 factors has to be approximately equal. One eye is, let's say, talk about anisoconia. What is anisoconia? Yeah. So what happens with them in binocular vision? Will they have binocular vision or not? Yes or no? Come on, fast. Yeah, visual acuity difference ആണ്. So അതുകൊണ്ട് എന്താണ് സംഭവിക്കുന്നത്? Yeah, perceiving size different ആയിരിക്കും. So binocular single vision ഉണ്ടാവാനുള്ള സാധ്യത കുറവാണ്. Yeah, exactly. So basically size matters, color matters. Intensity of that image of color ആയാലും അതിൻ്റെ സൈസിൻ്റെ ഇൻറ്റൻസിറ്റി ആയാലും ഔട്ട്ലൈൻ ആയാലും ഇൻറ്റൻസിറ്റി ഓൾവേസ് മാറ്റേഴ്സ്. ലെറ്റ്സ് സേ യു ഹാവ് എ വെരി ക്ലിയർ ഇമേജ് ആൻഡ് യു ഹാവ് എ വെരി അൺക്ലിയർ ഇമേജ്. Yeah, still the size of it will be same, but the clarity will be different. Then still it won't be possible for the both images to fuse in the brain. Got it? Now normal visual pathway. Let's say patient is having hemianopia or any visual pathway disorders. Will they have a problem with binocular vision? Yeah, it's already obstructed there, so we cannot move around. Now just talking about anomalies of binocular vision. What is the first anomaly of binocular vision? It's always diplopia. What is diplopia? Double vision. So what does this double vision has to do with the binocular vision? Why it is anomaly? What is the reason? So binocular system is breaking down due to inability to fuse the images. Reasons can be many. Okay, it can be many reasons. Due to any other reason, the patient is breaking down the binocular system because of the inability to fuse the image. Yeah, that's called double vision. So double vision, yeah. So it can be actually binocularly and as well as monocularly. So binocular double vision, how do you understand the binocular and monocular double vision? Let's say there is a patient who came to our OPD saying that I have a double vision. What is your first few questions as a history taking? Yeah, so you'll ask is distance or near, yeah, then you will ask which gaze it's increasing, what time it's increasing, yeah, this all matters, right? But basically you're supposed to ask them first is it monocular or binocular? Yeah, but you cannot ask them just directly, binocular, monocular, they never know, you have to educate them that first. So what you basically do, when a patient will come, double vision, cover one eye and ask them still the double vision is persisting or not. Yeah? Okay, so binocular diplopia is something, what? When you close the eye, let's say the patient is saying it's still double. Is that a binocular diplopia or monocular diplopia? Monocular diplopia. So when both eyes are actively using the fusion and then it's end up having double vision, it's called binocular double vision. Monocular is something when the patient is inactive with the fusion and still the diplopia persists. The reasons can be basically pathological. Break. Yeah, so I'll finish this and go then. So just for a casual information, whenever a patient who is having esotropia, it will be uncrossed diplopia. Yeah, when there is a patient who is having exotropia, it will be always crossed. So just remember like this, exo, it's crossed. Yeah, so just a yellow just a extra tip I should say. Or patient vanna parayana morning double vision koodalana. How do you manage it? What do you think first? You should always think about thyroid eye diseases. So just take the history well and understand what is the root cause of it. And if the patient is saying that the double vision is worsening towards the evening, then it can be always myasthenia, decompensated orthotrophoria. Yeah? Myasthenia gravis. Tell me, what is that? I have to teach you anatomy. Myasthenia gravis enda? ഇടയ്ക്കൊക്കെ anatomy തുറന്നു നോക്കാം. So, monocular diplopia can be basically due to these all reasons like cataract, post-surgeries, and sometime, let's say, okay, this is my last thing and then we'll go for a break. So when a patient comes to you, do we have to check pinhole for a diplopia patient? Do we have to check pinhole? Pinhole vision? Yes or no? Come on, it's late for you only. Break വേണമെന്നുണ്ടെങ്കിൽ വേഗം മറുപടി പറഞ്ഞോ. Yes, why? Why in diplopia? Why do you need to know maximum improvement? So basically, അറിയാൻ സാധ്യത കുറവായിരിക്കും. So usually നമ്മൾ pinhole വെച്ച് check ചെയ്യണം. We have to check with the pinhole is because when you use your both the eyes, okay, if there is a refractive error, higher refractive error with higher aberrations, let's say huge cylinder or huge hypermetropia, due to that patient is perceiving the image as double. Okay, here you can actually reside the problem by close one eye, ask the patient to put the pinhole in the center of the eye and ask him to see through this. Yeah, if the patient clears this, if the patient is saying no, now there is no diplopia, which means that could be because of refractive errors. Okay? So this method always, it's very useful for, when you go to the OPD, it's very useful. Before starting the refraction, before starting the visual acuity, get confused or into this complex. It's just two things. First thing, just ask them to close their eye, understand monocular or binocular, and then put the pinhole and understand whether it is because of the refractive error or not. So here half of the problem solves there. Yeah, so confusion you all know. Perceiving two different images, not able to fuse them together. So either, we are not going deeper to this, but I'll just tell you what is monocular diplopia reasons is always pathological. So just understand if the patient who is coming after post-cataract surgery and is complaining of double vision, then you should actually check for that. So whenever a post-surgery patient complains of double vision, make sure that is not a real double vision or is because of the post-cataract surgery or post any surgeries. Now binocular diplopia. So binocular diplopia has these many things to do. So drug induced ഏതെങ്കിലും മെഡിസിൻസ് സ്റ്റിറോയിഡ്സ് യൂസ് ചെയ്യുന്നവരെ ആൻറ്റി എപ്പിലെപ്റ്റിക് മെഡിസിൻസ് യൂസ് ചെയ്യുന്നവരെ ഇവർക്കെല്ലാം ഡബിൾ വിഷൻ ഉണ്ടാവാൻ സാധ്യതയുണ്ട്. സോ അതൊക്കെ ലൈക്ക് വൈ ഇറ്റ്സ് ഇമ്പോർട്ടൻറ്റ് വെൻ അവർ എ പേഷ്യൻറ്റ് കംസ് ടു ടേക്കിംഗ് ഹിസ്റ്ററി ഇസ് വെരി ഇമ്പോർട്ടൻറ്റ്. ദർ ഇറ്റ് സെൽഫ് ദ ഹാഫ് ഓഫ് ദ പ്രോബ്ലം ഇസ് സോൾവ്ഡ്. സോ ജസ്റ്റ് make a note of this. These are the factors who contributes to the double vision. No, I'm not going to that. Yeah, field of binocular single vision. Now actually nammal main topic il varne illu, and we are yet to reach the field of binocular vision and field of binocular vision. These both are different. Okay, one is binocular vision, which has a complexity. It's collocated with many factors. Field of binocular vision, where you are using that complexity, the area that you are using the complexity. So basically field of binocular vision use ചെയ്യാനായിട്ട് ഉപയോഗിക്കുന്ന ഇൻസ്ട്രുമെൻ്റ് ആണത്. എന്താ ഇൻസ്ട്രുമെൻ്റിൻ്റെ പേര്? Louder. Kinetic perimeter. So this is a instrument, so we don't go there deeper. It's not very important in binocular vision field. All right, so I think we can break for
We'll take a 15 minutes break. After that, you all have to be here around 11:45. Thank you. See, വരാന്തയുടെ എൻഡിൽ അവിടെ ടേബിളിൽ ടീ ആൻഡ് സ്നാക്സ് അറേഞ്ച് ചെയ്തിട്ടുണ്ട്. അവിടെ പോയി കഴിക്കും.
മനസ്സിലാക്കണം. അത് നിങ്ങൾ ലൈഫ് ലോങ് റിമെമ്പർ ചെയ്യണം. എൻ്റെ ഈ ഒരു ടോക്കിൻ്റെ ഉദ്ദേശം അത് തന്നെയാണ്. പ്ലീസ് കം. നിങ്ങളുടെ ടെക്സ്റ്റ് ബുക്കിൽ പഠിച്ച കാര്യങ്ങൾ ഞാൻ ഇവിടെ വന്ന് ബ്ലാബർ ചെയ്തിട്ട് കാര്യമില്ല. നിങ്ങൾ എന്തായാലും മറക്കും. ഞാൻ പറഞ്ഞു തന്ന കാര്യങ്ങൾ നാളെ ഇൻറ്റേൺഷിപ്പിന് പോകുമ്പോഴോ ജോലിക്ക് പോകുമ്പോഴോ ഫെലോഷിപ്പ് ചെയ്യുമ്പോഴോ ഒക്കെ നിങ്ങൾക്കത് യൂട്ടിലൈസ് ചെയ്യാൻ പറ്റണം. അറ്റ്ലീസ്റ്റ് 1 or 2 points, ദാറ്റ്സ് എനഫ്. ഐ എം ഷുവർ നിങ്ങളെല്ലാവരും ഫുൾ ജാർ സോഡ മറക്കത്തില്ല എന്ന് എനിക്കറിയാം. അതുപോലെ എല്ലാ കണ്ടൻറ്റും എനിക്ക് അങ്ങനെ ഇടാൻ പറ്റില്ല. പക്ഷേ some or other thing if you find it's easier or can tackle it, അത് വളരെ ഇമ്പോർട്ടൻ്റ് ആണ്. ഓക്കെ, എനിക്ക് കേട്ടോ, നിങ്ങളുടെ കാര്യം എനിക്കറിയില്ല. സോ എൻ്റെ ഉദ്ദേശം, ചേട്ടന്മാരെ എണീറ്റോ. പ്ലീസ്. സോ എല്ലാവരും എത്തിയോ? നോ, യെറ്റ് ടു കം. സോ അവർ വരുന്ന വരെ ജസ്റ്റ് ക്വിക്ക്ലി 1 minute I'll just share you few things. സോ ഞാൻ സെക്കൻഡ് ഇയർ പഠിക്കുന്ന സമയത്ത് നമ്മുടെ കോളേജിലെ ബോണസ് അവേഴ്സ് എന്ന് പറഞ്ഞൊരു സ്കീം ഉണ്ടായിരുന്നു. എനിക്കറിയില്ല സ്റ്റിൽ എക്സിസ്റ്റിംഗ് ഓർ നോട്ട്. നോ, ഓക്കെ. സോ ബോണസ് അവേഴ്സ് എന്ന് പറഞ്ഞാൽ നമ്മുടെ ബാച്ചിൽ ഓൾമോസ്റ്റ് 120 സ്റ്റുഡൻസ് ഉണ്ടായിരുന്നപ്പോൾ അൻവർ സാറിനെ നമ്മളെ CMAക്ക് പറഞ്ഞേക്കാനായിട്ട് ഭയങ്കര ടഫ് കോമ്പറ്റീഷനാണ്. 120 സ്റ്റുഡൻസ് അറ്റ് എ ടൈം ഗോയിങ് ടു CMA ഇസ് വെരി ടഫ് ആൻഡ് എക്സ്പെൻസീവ്. ആൻഡ് ദെൻ ഗ്യാതറിങ്, അതിൻ്റെ ബാക്കി എല്ലാ കാര്യങ്ങളും അറേഞ്ച് ചെയ്യാൻ ഇറ്റ്സ് വെരി ടഫ്. So basically what he'll call all of us all together in this hall. There were no dividers before. And he'll make us sit all together. He'll start having FAQ questions. So it's a questionnaire session basically. And first 100, first 50, first 80 people, whoever answers the questions, he will say the question, you have to raise the hand and answer it. So those people can go for the CMA. അങ്ങനെ ഐ എം എ ബി ബാച്ച് സ്റ്റുഡൻറ്റ്. സോ റെഹാനിലെ ബി ബാച്ച് സ്റ്റുഡൻറ്റ് എന്ന് പറഞ്ഞാൽ നമ്മുടെ ക്വാളിറ്റി എന്താവണമെന്ന് എല്ലാവർക്കും അറിയാം. ഐ നെവർ ബീൻ എ ഫെയിലിയർ, ബട്ട് ബി ബാച്ച് സ്റ്റുഡൻറ്റ് ഇസ് ജസ്റ്റ് ആൻ ആവറേജ് സ്റ്റുഡൻറ്റ്. ബിക്കോസ് ഫോർ മീ ഒപ്റ്റോമെട്രി വാസ് നോട്ട് അറ്റ് ഓൾ മൈ ചോയ്സ്. ഞാൻ വേറൊരു കോഴ്സിന് ചേർന്നിട്ട് ഐ ഹാവ് ടു ഡിസ്കണ്ടിന്യൂ ആൻഡ് കം ഫോർ ദിസ് ബിക്കോസ് മൈ മദർ ലവ്ഡ് ഒപ്റ്റോമെട്രി. ഫോർ വാട്ട് റീസൺ ഐ റിയലി ഡോണ്ട് നോ, ബട്ട് but I'm standing in front of you all because of that, so I'm very gratitude for that. I have all the gratitude for that. So now, നമ്മൾ CME അഹല്യയിലാണ് നടക്കുന്നത്. സോ അഹല്യയിൽ പോകുന്ന സമയത്ത് we know nothing about CMEs. Even, you know what is the full form of CME? Yeah, what is the full form of CMO? Sorry, COE. I'm sorry, it's not COE. Continuing optometry education. Okay, so that's our field, although nobody knows about it. Yeah. So നമ്മൾ CMAക്ക് കൊണ്ടുപോകുന്ന സമയത്ത് അഹല്യയിലായിരുന്നു നമുക്ക് ഉണ്ടായിരുന്നു CMA ഉണ്ടായിരുന്നത്. ആൻഡ് ഐ സ്റ്റിൽ ഡോണ്ട് റിമെമ്പർ വാട്ട് വാസ് ദ ടോപ്പിക്, വൈ വി വെൻറ്റ്, ഹൗ മെനി ഡേയ്സ്, നത്തിങ്, ആബ്സല്യൂട്ട്ലി നത്തിങ് ഐ റിമെമ്പർ. ബട്ട് ഐ റിമെമ്പർ വൺ പേഴ്സൺ, a really great, the person who have changed my career outlook of optometry. There was somebody. Okay, so we all were sitting in a very big, huge hall. Hundreds of people, hundreds of students are sitting. Then it's exhausting. You're seeing this all things first time. It was my first CME. Although, so somehow I got into the questionnaire, and then I also went with them. Most of them were batch students. It was too boring for me because my all friends are sitting there and chilling in the classroom. Yeah, so we went there. I still don't remember. Trust me, I don't remember anything out of that CME except one person. Her name is Dr. Prem Nandini. I don't know, I'm eligible to take her name out here. Whoever has come for the CMA might have seen her. Yeah? Yeah. So she was a lady who was standing on the stage, on the dais, and very simple. Very, very, very simple. Wearing a normal churidar. Yeah, wearing a very old glass. And very simple outlook. Just, not even pony, just she have tied all the hair together. Then you will be like, what is she doing here? Like, oh. Then I was like, really? Now I have to tolerate her. Already I'm fed up because my friends are at home or at the classroom chilling out, and I have to stay with this batch students. It's too boring. Trust me, guys, it's too boring. Batch is very boring all the way. I don't know how many batch people are here, but still, yeah. So this lady, the first outlook I had given to her was like, what is she doing here? But the moment when she started speaking, you don't know, real goosebumps comes out there. I still remember she was talking about a dome perimetry, which she had invented by herself, being an optometrist. being an optometrist, she have invented with her team, obviously, with her team, and a dome perimetry. It's called dome perimetry. It's a pediatric perimetry, first time invented. Like that's the only first instrument to be, tracked. All parameters kuda koodittulla otta instrument aanulladu all over. And she have invented that. I mean, it's their idea. She is a team there. So and the outlook never matches. You like whenever you go to CME, you will be like, oh, wearing suits. Yeah, you should look cool. You should be very professional. No. Very simple. She was very simple. So I don't remember anything out of that CME, but I remember that lady. Very respected. Later on, luckily, fortunately, I could get connected with her. She's in touch and she's such a lovely person. Remember, guys, why I do tell you this story, it's because you never know where you realize yourself. Maybe you all are bored of optometry. None of you are reading it because of you're passionate to that. Am I right? Yes. None of us know what is optometry and then come for study. Let's say you are going for MBBS. You know what MBBS deals with. Although the subjects are deeper and wider, but you know peripherally what is MBBS mein kya karta hai, what you have to do, what is the extra things. You never know in optometry. My mom said, go stay there. I stay there. Many of you, the story is same. Many of you will be like, the college is near to me, so why don't I go there? Yeah? Many of you like, you will never know why you came here. Yeah? Okay, so but don't fed up with your present. That inspiration, Dr. Prem Nandini, she's a vision scientist in LV Prasad. The people who have come for a conference might have heard her talks. Clear cut. Just talk. She was working in US. And no, I'm not actually praising, see, I don't use this point to take that way. I really want you to understand, you never know where you realize yourself. Sometime, maybe you don't want to do it yourself, but maybe you get into that, now no way out of it. So, many people will come and say, okay, anyway, you got married, why don't you stay? However your husband is, you stay there. Yeah, we do that. It's the same with our courses. You got into this course, we put a lot of money, lot of time. Now my age is also going. Okay, let me check in that. Don't do it. Realize where you can go, what you can do there. Optometry is not just about doing refraction. It's not just giving glasses. It's not just, correcting the optics of the eye. That's a basic of it. You should know the optics of the eye. Only then you can go for the further things. But that doesn't mean you have to always stick with the optics of the eye. The refraction is not only the end of the chapter. Okay? So, take your time. Go slowly. Don't get fed up of optometry. It's beautiful out there. Yeah, I mean, I don't know whether I cannot compare with anything, but people who had come for our conference, they might have seen. Yeah? What is the vast and huge area optometry covers? You know why in an optometry conference a neurologist have to come and talk? Anybody knows? When we used to conduct, now I'm no more part of Narayana, I quit the job for a few days, past few months. Now, but why? You should know how much you can do. How much area is, I'm not telling all together grab it and hug them and sit. No. You have contact lens, maximum, I'll tell you. If I'm wrong, you can correct me. You know refraction. You know about contact lens, options of contact lens. You go contact lens. Low vision, binocular vision. Ho gaya? Khadam, tata, bye-bye. Go home, take money, eat food, and then sleep. Life is zindagi mein, aaram ho gaya. It's not about it. See, this is also beautiful. I'm not telling the people who's just sitting there. It's not, they are not doing anything wrong. But when you have a door to open, please explore it. It's not about doing masters or just doing PhD, just doing OD, getting dignified, higher standard. But when you realize the real passion of it, I don't know for boys how much it's actually working it out, but even I have a colleague, many colleagues who do vision therapy in our clinic, male peoples, holding a kid. Yeah? You might have seen Shobik when you came for the conference. The glass one. Okay, leave it. So, we have it. So, understand it. Take your time. Maybe one at a point you will realize it. Optometry needs you. It's not who you need it. Or you fed up with that and still continuing it. Some or other point, something, some subject is waiting for you. Okay? Done? Got enough motivation? No, it's not a motivation. I see, for me, when I finished my graduation and went for a clinical internship, it has given a huge exposure. Trust me, it was horrible. My internship, you cannot even move from one place to other place. Strict like anything. You have to maintain logbook. Each morning and 1 hour, every 1 hour, the HOD will be roaming around, not talking each other. Even the person who is sitting with you, the senior who is posted with you, you cannot talk to them. Except the case which is in front of you. But the exposure you get there, and you know, the challenges you have to face, that's really, really beautiful. And then you can decide what you have to do. Just because of you have to get a good salary, don't do masters. Just because of you wanted to clinically, you know, yeah, I might get a bigger post than her, so I'll do a fellowship. Don't do it. Love it, then marry it. Just don't marry and then, I have to prefer. Don't do that. Okay? It's not a motivation. I wanted to pass some information because I was there in your position, one wing. Never ever lied. Okay, anyway, you know, when I'm in B batch, you definitely know how much ever I loved optometry when I was a bachelor student. But the point when, it took a long time for me. Forget about the CME. CME was like put a lot of images on that person and I understood this is not just doing refraction. Still I was like, okay, I have to finish it 3 years. Okay, yeah, so I have to take care of it, take care of family. Yeah, I have to be responsible. That person who wanted to do just immediately after internship to join for a work, I spent 2 years for my fellowship. Again, borrowing money from family. But now, I'm very proud of it because I did it and I can do it. Still, I can do it. It's not because I'm saying it's like somebody I'm very grateful to talk about. I'm very smaller. I'm not just raising grass, that's it. But all of you, this you might have heard with everyone, but trust me guys, this is my real experience and the experience I've seen with surrounding people. So don't shunt your growth. Understand optometry, love it, and then study it. Okay, so let's come back to this. Complaints. So in our talk, the next session was complaints. So what are the complaints? Now when you go for, yeah, okay. So when a patient comes to a clinic, you should know, every patient you cannot practice binocular vision or orthoptics, right? Because it's time consuming. The chair time is quite long. So every patient, each and every patient you start doing this, it is not at all convenient for the system. So when you have to check for binocular vision, when? Let's say patient is coming for a driving license. Do you have to check him for binocular vision? All together? No. Necessary things. Yeah? Let's say there is a patient who is coming as a headache. Do you have to check him? Yes. So it depends on the complaint the patient reports to you. You have to decide whether the patient requires only a normal optometry workup or have to do an intensified binocular vision workup. Alright? So headaches are always an indication for the binocular vision. Blurry vision or focusing issue. Blurry vision, don't take it like a normal blurry vision. It's not nearsightedness, farsightedness, myopia, astigmatism, hyperopia. It can be anything. But focusing issue. This is what matters. Let's say somebody is coming and telling you when I'm working on the laptop, suddenly when I look at somebody who is coming to him, he is not able to identify that person. Or when a kid is looking at the board and suddenly writing it down, it's not getting cleared. Or it's taking some time. Or he has to blink his eyes. Or he has to squeeze his eyes. Yeah, these are supposed to be noted. You know? And diplopia, yeah. Diplopia is always a chance. Like when you put the pinhole and understand there is no other factors, physiological factors, then it's just a refractive error. That's the exception. Apart from that, it's always good to check a diplopia. Until unless, let's say there is a patient traumatic brain injury, or road traffic accident, post of this all, somebody is coming and telling you diplopia, you cannot check all these binocular orthoptic factors for that people. Yeah, so you have to refine it. Still, these are just basic of it. From this itself, again, you have to refine. And then next one is eye pain and eye strain. Very common, you know. Confusions. Very best indication. That itself is an anomaly of a binocular vision. Now, near work difficulty. How many of you, okay, any one of you has got clinical posting? No. No. None of. Clinical posting? Yeah? You got it? Okay, leave it. Forget it. Now, near work difficulty. People, especially when they use a lot of computers, or people, let's say goldsmith, you know, or a carpenter, or thread workers, stitching people, tailors. These all people commonly say about the near vision task. Once they start focusing, it will become unclear, or it will become double, or it will become overlapping. So these complaints are very classic symptoms, or sorry, indications of binocular vision evaluation. Heaviness of eyes and glare. Now, why glare is important? Glare, there are many different varieties of glares. Okay, reasons are too much. Too many, two numbers of that. Too many numbers of them. Why glare is important in binocular vision? When it comes to accommodation, there is a huge fact for a clear single vision. Clear. That's what matters. So if it's not clear, you still have a chance the accommodation can be defected. Okay, so glare, many people like post-refractive surgery. So from my experience, if I speak, so post-refractive surgery, LASIK surgery, they'll spend a huge amount on it and they'll come back after a few days saying that they have a huge glare. Or basically they say that they have a blurred vision. So when you start checking for it, you realize it's a glare. So now what do you do? Already refractive surgery is done. And you know, LASIK is always expensive. Yeah? So what do you do? So remember, it is not always a high-end examination you have to do. Send them for that, send them for this, no. Or resurgery, no. Why don't you check for aberrations? Lens, on lens. Okay, so if the accommodation is very much activated, there can be a chances of glares. Okay, so that's why this glare is important here. So whenever you check for the accommodative factors with a comfortable room light, then you will understand it. Okay, now this patient is having some trouble with the accommodation. This could be the reason. So you can do topography or eye trace, then understand what is the defocus in that, and then give a treatment for the patient. So these are the common complaints. Guys, this is not just the complaints. These are the common complaints. Okay. So past history it's always important. The very, very important part is ask about NVD. What is NVD? Near vision demanding task. Okay. But good, engaging. So all the way, near vision demanding task. What is near vision demanding task? Whatever activity you do which requires more of near vision than a distant vision. That's account of near vision demanding task. Let's say software engineer is coming and telling you he's having a huge headache. Yeah? The first thing you're supposed to ask him how many hours of near vision activity you do or how many hours of system you use in a day. Okay, so it's always important to understand. Drugs recently used, So let's say epilepsy one, some kind of steroids still causes binocular vision problem. Okay? Head or ocular trauma, any trauma recently they passed through, thyroid diseases, cancer, some cancers, not everything, childhood strabismus or amblyopia. Okay, now why amblyopia here? What is amblyopia? Lazy eye. So one eye or either of the eye, both of the eye can have. Okay, tell me, amblyopia is monocular or binocular? Is it like one eye can only affected or both eyes can be affected? Yeah, so you know that pitch basic. Okay, good. So yeah, so when there is a unclear vision happening, unclear vision fusion is happening since long time, this still can cause trouble with the binocular vision. Now, let's coming to the most important part. Now we are going to forget about all the pathology, physiology, anatomy, everything. Now here you have to start the basics. What a orthoptics evaluation account of? At most, always refraction. Always refraction. Until unless you do not correct a refractive error of a person, you can never treat him further. How much ever treatment you give, he'll be unhappy. Okay, so refraction is always important. In refraction, basically there are 3 steps. What are the 3 steps of refraction? Yeah, so subjective, objective and binocular balancing. So can anyone tell me few methods of binocular balancing? Prism dissociation, alternate occlusion, okay, fogging. Then എവിടെയോ കാണാതെ പഠിച്ചു വെച്ചിരിക്കുകയാണ്. Yeah. Okay, so you all know about binocular balancing, right? Yeah. So first you will do refraction. So before refraction, what do you have to do? Uncorrected visual acuity. Yeah. For distance and near, this both are important. And near should be mentioned along with the the distance you are measuring in the near vision. Okay? And then what do you do? Then do refraction, give a best corrected visual acuity. So here, after objective refraction, you give a subjective acceptance. And then do binocular balancing. So basically, what does this binocular balancing do? Is it correcting the spherical or cylinder or both together? Accommodation, yes, yeah, in a minor way, yeah. Now my question is very simple. Does that mainly deal with spherical or cylindrical correction? Okay, so what do JCC do? So why you need a JCC separately when both will be corrected in binocular balancing? Yeah, refinement, that again, you are refining by binocular vision, you are refining the refractive correction, right? So my question is this, binocular vision when you, binocular balancing when you do this, is talking about spherical correction alone or cylindrical correction along together? JCC class. Okay, tell me. So basically it deals with the spherical correction of the patient. Okay, so binocular balancing, yes, in one way it has to deal a lot of thing about accommodation as she said, but basically it deals with the spherical correction. Cylindrical correction will be done with always refined by JCC. Yeah. Now, a small simple thing. Again, it's a practical question. Let's say a patient who has come to you who had +1 correction, spherical, and 0.50 you had given as a cylindrical. Okay? Minus 0.50 cylinder and +1 spherical. This is the final correction of the patient. After binocular balancing, hey there, you have got something to ask me? Good? Can I continue? Perfect, thank you. So, when you refine it, you have to first refine the spherical. Now, when you use JCC, you are refining the power and axis correction. Now, my example was +1, -1. So, minus 0.50, yeah. So, when you do JCC, you found that you have to add 0.25 again. For example, 0.50 you have to add extra cylinder. You refined everything. Now patient's total correction is +1 with a -1 cylinder. right? How are you going to prescribe these glasses? Will you give the same correction? Okay, so basically, just an information I'm passing through. It's nothing dealing with the binocular vision. Yeah, it deals with that, although. Basically, when you add cylinder, you are supposed to reduce the spherical correction. Okay, how much ever cylinder you are giving, you have to reduce that much amount of spherical. That's how it balanced always. Because you cannot keep checking like, you will check spherical, then do JCC. JCC may again there will be changes and then they again go for binocular balancing. It won't happen. So this is a method. So whenever you add or reduce the cylindrical correction after JCC, you are supposed to, approximately, parallelly you are supposed to do the same thing with the spherical one. If you are adding cylinder, you are supposed to reduce the spherical correction. Okay? Now, yeah, dispensing. Why dispensing is matters in binocular vision? It's very important. Just after refraction, you cannot directly go to orthooptics evaluation. Let's say a patient who had a problem of headache and you found there is a huge plus correction coming for the patient. And once directly after your refraction, if you directly go for an orthooptics evaluation, there is definitely accommodative problem because the patient need a huge plus correction. Yeah? So what are you going to do? You have to prescribe the glasses first. So do not rush to any patient. First, correct the refraction, ask the patient to adapt the glasses, and then again call the patient for a proper detailed orthooptics evaluation. Okay? So dispensing is always important. Sometime contact lens needs to be given, irrespective of patient wants it or not. Yeah, ultimately the decision is from the patient. It's always the protocol, but there are few cases that we have to suggest them. You have no options, such as yeah, talk to me. Such as uniocular. Such as uniocular. Aphakia, there is no binocular vision at all for aphakia, right? Like it's very, very less. So that's what I told you. When you need to have a binocular vision, there is minimum criteria you have to meet with. So you can artificially make for the patient, but then it's already not existing. Uniocular amblyopia, yeah, but then it's not the exact case. What is emetropia? Can you, one of you please stand and see? Okay, I'll call. The one next to, okay. Yeah. Yes, you. Emetropia. I know you're very sleepy boat. Huh? Normal eye. What do you mean by normal eye? Can you speak a little louder? What is emetropia then? So which has got emetropia or emetropia got refractive error? Sit. Which one has got refractive error? Huh? Emetropia. So uniocular emetropic cases basically. Thank you. Uniocular emetropic cases. Let's say patient is having one eye higher refractive error and another eye either normal or lesser refractive error. So in these cases, when you give two different powered glasses and the thickness of the glasses are going to be different, thus the vertex strengths and everything matters there. So in these such cases, it's always important to give a contact lens and then check binocular vision on top of contact lens. Okay, so this is again very important. Now coming to a proper orthooptics evaluation, it's always important to do sensory evaluation. Yeah, so what all includes, so basically there are two things. Sensory evaluation and motor evaluation. This isolation is called orthooptics evaluation. So sensory evaluation includes, you have to check for the scotoma. Second thing, you have to check for the double vision. Third thing, you have to check for the stereopsis. Okay, and then motor evaluation. Motor evaluation includes motility, ocular motility. Okay, it's not your motility. Then squint. Yeah, what is squint? Let's give him a clap. Angishtapato, you're active. At least I know you're not sleeping, but many of them are sleeping behind. Yeah. So, virgins. Virgins, what is virgins? It can be convergence or divergence, and then accommodation. We know what is accommodation. What is accommodation? All right, just to see the things clear and best, yeah. So, this is what motor evaluation. Basically, in motor evaluation, this is what we are checking for. Okay? What all? Mobility, squint. Perfect. Now, orthoptics evaluation. These, as a practitioner, this is nowhere in the textbook. Please do not note it now. Don't write it. Okay, just for information. Here, orthoptics evaluation, first thing you should understand is time. It takes time. It's no matter give and take, just in a way. Yeah, it's not a within minute of matter. You need to have a really good chair time with the patient. Yeah, expect minimum of 45 minutes to do it. Whether you take 1.5 hours, no matter, because it depends on the patients, how much they are, because it always has to deal with a subjective and objective response. So you have to see something, patient have to respond, and if that does not correlate, you might have to recheck it. So you need to have a break with the patient. So it's always about time. It takes time, and that's how it works. So make sure whenever you take a patient for a binocular vision assessment, you communicate with the patient the need of the time, and the patient has to be seated with us till it finishes. It is going to take time. Okay? And occupation. Occupation of the patient is very important. I don't think so I have to go more in this. Patience. Nalla kshama venam. ചിലപ്പോൾ പേഷ്യൻറ്റിൻ്റെ കണ്ണ് ഇവിടെ ഉണ്ടാവും ഒരു കണ്ണ് പേഷ്യൻ്റ് ഇപ്പോഴും പറയും യെസ് ഐ ക്യാൻ സീ സിംഗിൾ മാം. Corporation and patients has different things. Corporation, I cannot keep that as a corporation, basically. No, that's a fair point. See, being a practitioner, for us, we have to cooperate with the patient. Yeah? Patient does not have to cooperate with us. They are not coming here to play with us or something, right? We are not entertaining them. We are medically evaluating them. Let's say wheelchair patient is coming and you are expecting him to come and walk and just tell me what is this? No. We have to cooperate to the patient. So the point of cooperation is good. The patient have to be cooperative. We think that. But patient do not have to think about it. Right? You cannot expect a stretcher person to come and then check for a visual acuity sitting like that. You cannot. Rather, you have to use some other method. So that's why. So cooperation is always about us. How much do you cooperate to the patient? No matter however the patient is responding, whatever the patient is responding. It is always how you cooperate to the patient. And now position. Position, what do I mean by this? So when we had a workshop recently, we found many people are doing NPA, just using RAF ruler. One is sitting here, another is standing here. Okay. Sometime we'll see one is very short, another is very tall. Both will be sitting. So positioning of eye is always important. If you do not have a real track to the patient, okay, let's say she is my patient, I'm checking her from over here. So when I give her NPA, she's going to look at that object. When she look at the object, when it's come closer to her, her eyes will be already shutting. You know, the lid will be already moving. You will never know what is happening there. So rather I go down to her level and understand it. That's where I'll really find out the values accurately. So the position always matters. Now observation, very important, because many times patient can get confused what we are asking to them. For example, RAF ruler, you have a target of convergence, a line with a dot. Is it so? Yeah. How much ever you explain to the patient might say double. And that double could be never related to your objective value. So when you're objectively seeing the eye still aligned, still maintaining the convergence. So that could be the patient is explaining about the line. So observation is always important. Just don't note it out when the patient sees that, oh, now it's double. Don't note it out. Observe it yourself and make sure the patient is comfortable and understood the theory and then talking to us. Okay? Counseling. Very important. Why counseling is important over here? Because I'll tell you, most of the time, your 50% of time will go only in counseling. First, you have to tell them what all tests you are going to do, because it's not a single instrument you are going to use in an orthoptics evaluation. You have multiple things to do and multiple way to do. Okay? Maybe first day you have evaluated, second day I might be evaluating. Still, you have to explain everything, because that's how hand to hand there is a different way, different method, and it's a long procedure. It's not a single instrument you go and they will click the image and then you'll get it. It's not a fundus photography. Yeah, it takes time. Along with that, there are multiple things to do and multiple response to be recorded. So that's always important. Okay, so counseling before the evaluation and after the evaluation is very important. Let's say if the patient is using a lot of mobile, gadgets use are too much, and then more into near vision demanding tasks. Let's say it's a school kid. Rather than, there you really cannot approach it as a counseling, but you have to make sure the patient will not continue doing that, at least for your satisfaction. You should make sure that. So you should give a proper time to communicate with the person the way he wants us to be communicated, and then send the patient home. So counseling is always important. So once you have all these factors, you are actually perfect. Okay. Now, refraction includes all this thing. Uncorrected visual acuity. Why uncorrected visual acuity is important? Yeah, exactly. Then, let's say there is an amblyopic patient. The patient never know what is amblyopia, or nobody has told him in the past what is amblyopia, or he has an amblyopia. So, unaided visual acuity is always important. Okay, it's not about amblyopia, we have to roll it out, but it is always important to roll it out, because there are cases something like near vision demanding task. Yeah? So what this near vision demanding task does? It stimulates a lot of accommodation, convergence altogether, too much. And it end up having spasm of near reflex. Yeah? So in these cases, whenever you check their vision, it will be absolutely no vision. And you dilate and then bring them, they'll adamasivate 6 by 6. You'll be like, why this patient is doing this thing? No, trust me, you'll do that. Okay, it's because the patient's condition is that. We cannot blame him. So, it was your mistake, you did not account it undilated or unaided, whatever. Okay, so it's unaided is always very, very important. And retinoscopy? Yeah. Objective retinoscopy, that's it, nothing else. Subjective acceptance. Now, giving subjective acceptance, you have different method to approach it. You can, basically the thumb rule is, what is the thumb rule? Subjective refraction में maximum plus, minimum minus. Okay, it doesn't work always like that. So, acceptance has to be according to the patient's optical situation. So, we'll talk about this in the coming PPTs. BCVA, best corrected visual acuity for the distance and near. And make sure whenever you write a near vision acuity, you should always mention about the distance you checked. Okay, let's say you got an N6 vision. So, you should mention it how? N6 at 35, whatever distance you have checked, okay? So, JCC and aided diochrome test. Okay, now why diochrome is important? Exactly. Binocular balancing, we already spoke about it. Borish delayed test. What is Borish delayed test? What is Borish delayed test? Why do we use them? Why is it important? Have anyone of heard about that? Never? Okay, so I think I have to go there. So Borish delay test, what you basically do, you have a refractive correction given to the patient. You know what is NRA? No, NRA. Exactly. So, negative relative accommodation. So, you have to measure the negative relative accommodation of the patient. You will get a particular value. Along with that, you have to add the working distance. Okay, and give a target to the patient. And then you have to binocularly start defogging the patient with 0.25. So my NRA is 1.5 and I'm adding 1.5, which means plus 3. So on top of the refractive correction or whatever your subjective acceptance, you have to keep this plus 3 and then start defogging it. Okay, until the patient say the what? Yes, the clear point. Okay, there you have to stop. And then again you have to individually check the vision. This is what Borish delay. See, Borish delay is not very complicated, but yet you should actually know about the theory of Borish delay. So basically, even if you don't have a, eye drops to put for a dilated evaluation, I'm not talking about fundus, but the dilated retinoscopy or dilated refraction, you can actually use Borish delay and refine the patient's power. Let's say a patient is coming to you again. Patient is telling complaint of headache or whatever, so on. Now you are at a peak of, you have to do a dilated refraction for that patient. And patient is having exam day after tomorrow or tomorrow, but it should be a cyclorefraction. So whenever it comes to a cyclo, you cannot just next day he can go and attend the exam, he cannot study at all, basically. So what do you do? But there is no option. You have to do it that day itself. What do you do? So Borish delay is basically giving you the bestest correction, okay, without activating accommodation. So basically, why are you putting eye drops or cycloplegics? Yeah, to relax the accommodation. The refraction, whatever you get, should not have any component of accommodation. So you got it there. So when you do a proper Borish delay, I'm not telling you to just go and practice it, but you should always know there is a method to do it. It's not like patient might pay and come to us and go in, unfinished or incomplete. You have a way. You can still practice this and give a glasses. But it has to be done, thoroughly. That's it. Very adequate, proper. Okay? It cannot be like just done like a normal acceptance or something. You have to be very careful. So when you do a careful evaluation of Borish delay, you can actually prescribe the glasses even without dilating it. Okay, so here one small question. So you know difference between mydriatis and cycloplegics, right? Yeah. So what is the basic difference? Quick. So the red one, she's very busy at her world. May I ask you a question? Yeah. Tell me, what is the difference between mydriasis and cycloplegics? Anything you know, I'm not just asking a question. Whatever you know, you can say. What is cycloplegics? Yeah, so mydriatis is also doing dilation, right? Yeah, please sit. Thank you. Tell me.
Pupil dilate and mate cycloplegic.
Even cycloplegics dilate.
Accommodation relaxing.
Alright, so the basic difference of mydriasis and cycloplegics are, mydriasis does not relax the accommodation, it only deals with the, pupillary muscles, exactly. Cycloplegics deals always with the accommodation as well as the dilatation, yeah. Now let me ask you a question. There is a kid who has come to your clinic and very uncooperative, yeah, so-called uncooperative. You have to put a cycloplegics refraction. The patient is keep crying whenever you put and resisting a lot, a lot of things are happening. You should know the patient is really dilated or not. Or is the patient is still like when the patient is crying, when you do the refraction, it can fluctuate here and there. So you're not sure about it, whether the accommodation is relaxed or not. How do you know it? No. So cycloplegic in the patient is dilated, but you wanted to assure it the accommodation is resting. So when the torchlight you put, it's actually still dilated, right? So it does not keep any changes. So cycloplegic has two actions. One is dilatation, second is accommodation relaxation. Which one happens first? Dilation. Okay, now let's have a debate. People whoever support dilation happens first have to raise the hands. Have to raise the hands. Whoever said yes, have to raise the hands. Or else I'll start making you stand up now. Only this much support? Whoever says dilatation happens first, have to raise the hands. Raise the hands, I didn't ask you to point it. You're not nursery kids. Yeah? Okay. Whoever is saying accommodation relaxation happens first, raise their hands. Please stand up. Please stand up. Can you please stand up? Please stand up, ma'am. Yeah. Let's clap for them. So it's always, thank you. So it's always, why don't you clap a little closer, yeah? It's cause nothing. Yeah. I know you all are very sleepy, huh? That's why you're not even clapping well. All right, huh? Nee oranganilla enakku manasilayi. That's okay. Fine. Anyway, so cycloplegic mein, it's always accommodation, relaxation happens first. And then dilatation. So when you know the patient is completely dilated, which means the patient's accommodation is already relaxed. So make sure whenever you use the cycloplegics, the complete dilatation happens and then you proceed for the refraction. Okay? Yeah. So sensory evaluation includes stereopsis, Word-for-dot test, and red-green Google disparity checkup. So talking about stereopsis. Have you seen any of this? What are they? First one. The first one is Lang stereo test. Second one is Randout stereo test. Third one is Titmus fly test. So most commonly used one is Titmus fly test. Then we still use Randot because it's quite accurate. The dots, whatever they have seen. So basically what you have to do, you have to wear that glass. What are these glasses called? Polaroid glasses. So you have to wear the Polaroid glasses. What do these Polaroid glasses do? Why are we using? Okay, I understood your concept. You are trying to say that one eye will be polarized and another will be unpolarized. That creates the depth. Why? Why does that have to create a depth? Retinal disparity. Okay? Yeah. So now here, when you look at the Titmus fly test, you have to wear the glasses. The patient have to patient have to catch the fly's wings. You know, you have to catch it like this. So it usually works with the people cannot identify it like when you know that's a very lesser stereopsis, you please try this. If not, it is always better to check a Randot stereopsis. Why? Why? Because it has no clues there. If it's a fly, you know, you can actually mimic the person. The examiner is telling you to do this. Maybe you can imagine, okay, maybe the wings could be like this. So always Randot stereopsis is most accurate. And what is a normal stereopsis? What is the unit of stereopsis? Arc? Say loudly. The yellow one. What is the normal range of stereopsis? Or what is a normal stereopsis? If you know, you say. If not, no problem. Cool. Any idea? Please say. Thank you. No idea. Next one is like, please don't ask me. Okay. You know? Anybody know what is a normal? What is the unit? Who all are the practitioners here? Who all are you are practicing? Okay. Who all are the practitioners here? You all are students. Practitioners. Okay, seconds of arc is the unit. Seconds of arc. Please note it down. It's very important. When you go for an internship, don't be a dumbo there, okay? Please understand some of this. Unit of stereopsis is seconds of arc. Okay? Okay, cool? Yes, good. Because I was a dumbo. I never knew those. So, stereopsis. The normal one was a 40 seconds of arc. 40 seconds of arc. So, when you start checking the Randolph stereos test, I'll just talk about Randolph stereos test because, yeah. So, the dots you can see in each column. Yes? So, there are 3 circles on that. So, one circle which is popping out, they have to touch and show us. So, from higher resolution, higher stereopsis state, it will come tougher and tougher and tougher. There are 10 of it. According to that, there will be a chart given to you, and then you have to understand till what the patient have responded to you, that correspond to what value you have to mention it. Seconds of arc. Okay. Now, let's say the patient is not at all able to understand even the first one. Now, we have to go for the little easier one to the patient. That there must be a reason the patient is not having that much capable stereopsis. Yeah. So, you can show that A, B, C. The animals you can see that one. Yeah. That is even more easier clues. It's a bigger objects and easy. Okay. The boys at the last bench. Hello. I didn't see you on the first. What's going on? Welcome to the class. Myself, Arya. Oh, great. Thank you. Good name. Nice to meet you. Will you please keep quiet for some time? Yeah? Thank you. I appreciate that. Now, coming to the other one. Now, let's say the patient could not. Now, let's say the patient could not appreciate the dots as well as the animal. Please respect time. Now, when the patient is not responding to the animal also, you have another clue to give him. You can see 4 boxes there, right? 2 sets of boxes are there. Now, in 4 boxes, there will be hidden shapes or pictures or something. Now, patient have to respond to you. And one will not have any shapes. So, there you can understand whether the patient is, yes, understood and telling, guessing or not, basically. Yeah, one square is not having any shapes over there. Rest 3 is having. So, if the patient is randomly telling, there itself you will be able to know. And that's a very easiest clue. Okay. So, it will look like something. Have you ever tried stereopsis? Have you ever tried using them? No. Yes? No. So, this is how it will look like. So, without the glasses, the right image, the left image, it is actually without the glasses. It will look like that. So, when you wear the glasses, when you have an active stereopsis, it will look like this. So, what is the shape over there? Circle, basically. You go, okay, it will look like a ball because it's a depth. Basically, it's a circle. 3D, yeah. Now, word for dot test. What do you know about word for dot test? Chop fast. We have no time. Come on. What is word for dot test? What all you use for a test? Okay, you are checking the separation. I understood. What all equipments you need? Okay, okay. So, red green goggles. Okay, chart. What chart do you use? Target chart. Yeah? And then, what else you need? That's it. Okay, distance. Okay, fine. So, we are already bored with these pictures. You always know you have to wear the goggle, red corresponding to right, left corresponding to green. You have to show the target. Patient have to respond to you how many dolls the patient is seeing. Accordingly, you will start getting the interpretation of that. So let's say the patient is finding that first picture A. It's a red and 2 green, and then there is a yellow light or the dominant eye light comes up. So you will understand there is no diplopia, there is no separation. And according to the interpretation, I am not going for the interpretation because it's already read by all of you. So I'm not going to do that. So you know what is all this interpretation talking about, right? Now, basically, word for dot test is talking about the flat fusion. Okay. So whenever next time somebody come and ask you, why do we do word for dot test? Better say to exactly. flat fusion ability at distance and near. This is what we are using for a Worth dot test. Okay, please stop saying that checking separation. Try to use a better term and better understanding of it. Worth dot test is not just to understand the separation. It has a lot more to do with it. Okay, so let me ask you, anytime anybody wondered why these targets had been always given as a triangular shape or like, always in a cornered shape? Come on, chop chop. Boys, anytime thought of like that? Every day. Worth dot test dot test vadi. Enikku endha vadi? Okay, so worth dot test yes.
വേണ്ട അല്ല സെപ്പറേഷൻസ് വേറെ വേറെ മനസ്സിലാവാൻ വേണ്ടിയിട്ടാണ്.
Right. Yeah. You can even give it in a wide circle. Still you will understand the separation. You're not a kid. See, everybody understand that. Yeah. Field. No. Field actually does not play anything here. Why? Why? There is a specific diagonal shape. Yeah, not triangle. It's a diagonal shape for a Worth dot test target. So when we meet again after lunch, I'm going to ask each one of you and you have to come here and say what is the reason, okay? Now, you are supposed to ask me this question. Isn't it? Good. Yeah. So, Worth dot test is very important when the patient is not able to appreciate 40 seconds of arc. What is seconds of arc, maybe? Yes, good. So 40 seconds, whoever is, okay, below does not means 30 or 20 or 10. That's a good stereopsis. Below, which means the higher number of it. Let's say patient is explaining only for 100 seconds, 400 seconds, 200 seconds. Definitely you have to check for the Worth dot test. It's the biggest indication of that. Now, I'm going to talk about something very interesting and you might have not heard about it. Central scotoma. What do you do with central scotoma and Worth dot test? Okay, before that, what is central scotoma? Scotoma at the center. Yeah, perfect. Yeah. I mean, I was thinking like, എൻ്റെ കോളേജ് കഴിഞ്ഞിട്ട് 7 years ആയി. ഞാൻ വിചാരിച്ചു നമ്മുടെയൊക്കെ പിള്ളേരുടെ ചിന്താഗതി മാറിയെന്ന് വിചാരിച്ചിട്ടുണ്ടായിരുന്നു. ഒരു രക്ഷയില്ല. നമ്മളൊക്കെ എന്താ പറഞ്ഞിരുന്നത് അതന്നെ എപ്പോഴും പറയുന്നത്. ഓക്കെ, സോ ടെസ്റ്റ് ഫോർ എ സെൻട്രൽ സ്കോട്ടോമ. നമ്മൾ Worth dot test ഉപയോഗിച്ചിട്ട് സെൻട്രൽ സ്കോട്ടോമ മെഷർ ചെയ്യുന്നുണ്ട്. How do we do that? Okay, basically Worth dot test can be checked in distance and near. Not can be, should be. Okay, you have to check the distance and near because sometimes patient might not have any separation or double vision at distance, but patient will appreciate that in the near, either of the ways, So it's always important to check in the two different distance. Now, you have to hold the test as 40 centimeter when you check for a central scotoma. In central scotoma also, you have two different scotomas, okay? One is sensory and another is a monocular scotoma. So, before going to that, we should know how to check this. So ask the patient to continue fixating 4 dots and to report the further number of dots drops to either 2 or 3. Yeah, so you're giving a target 40 centimeter. So forget about that. Now I'll tell you what it is. So 40 centimeter you're giving the target. So basically what target they have, there will be a torchlight kind of target. So which has a aperture with the 4 dots and the light coming into that. And now the patient, you have sit at a 40 centimeter distance. You are asking the patient to keep looking at the object. And then slowly when you understand, the patient start, they have to say that either of the eye is suppressing. Another way, it is something like the patient have to say either they started seeing only 3 dots or 2 dots. Okay, after staring, should understand this. They are keep staring at it and then they responded to this. Maybe first time when you check it, it's like, yeah, absolutely normal. The patient is seeing 4 dots and everything is normal. It's not just that. Yeah? So that's why it's important to say, ask the patient to continue fixating 4 dots. Continue fixating. Yeah? Now, slowly start to move the test away from the patient. Now, where are you right now? What distance are you? 40 centimeter. Now you start to move away from the patient. Okay, and ask the patient whether the patient is start reappearing the dots or not. Is it reappearing or not? So already patient have lost either 2 of the dots or 3 of the dots, either red or the green. Yeah. Now when you start moving it away, you have to ask the patient what is that reappearing or not. Okay. So stop when the patient reports a change in the number of dots and estimate the distance at which it occurs. Now you stopped. Let's say after 1 meter. Let's say 60 centimeter, when the patient is telling, oh, no, the number has changed. Stop there, measure the distance. It's very important to measure the distance. Now, if the patient see all 4 dots at 3 meter, the test stops and you can record no separation to 3 meters. Get me? What is that saying? If the patient see all 4 dots, when you start moving from 40 centimeter to 3 meter of distance, which is a half of the distance, yeah, then you should say, you should stop doing that at 3 meter distance and then record it as no separation. Now we have an exception cases. What could be the patient have said, yeah, it disappeared. Yeah, maybe patient can see, right? We said one possibility. Patient said no changes, it's always 4 dots. Now the patient can say, no, it disappeared. Or the patient can say it's reappeared after some time. So what is that cases? You can see suppression scotoma and unilateral scotoma. So what is this suppression scotoma? They were looking at that and either of the dots disappeared. You started moving it. And in one particular distance, the patient says it reappeared. Yeah, that is called sensory scotoma. Okay, so the sensory scotoma is determine which eye is suppressing, ask the patient to cover the eye that is not suppressing and to report whether or not the suppressed dots reappears. Okay, so now you are moving it from 40 centimeter of distance and you are asking the patient to close one eye and then see if that dot is reappearing. Yeah, then that is called sensory scotoma. I know this is little too much to understand, but it's very important in the part. That's why I'm just explaining you. Just understand only so much. Worth for dot is 40 centimeter mein karna hai. You have to do it 40 centimeter. Yeah, you have to ask the patient to keep fixating on it. Ask for the patient is getting any disappearance of the dots. Keep moving it away from the patient. And if while closing one eye, if the patient is responding, there is a the dots reappearing, then account it as a sensory scotoma. Now what is unilateral scotoma? Even after closing one eye, still it's not reappearing, which is called unilateral scotoma. Yeah, I hope this is a new information about Rutherford test for many of you. Is it so? Yeah, thank you. So that's what about Rutherford test. So why do we do Rutherford test? Yes, exactly. Motor evaluation. So as the name indicates, motor evaluation is about always what? Motors. What is motors here? Muscles, movements. Yeah. So extraocular motility. How do you check extraocular motility? Broad edge test. And what is the other method? Okay. So do you have a name for that? Hess chart. Extraocular motility. Hess chart for extraocular motility. Just to check an extraocular motility, you have to make the patient sit in front of that screen and do all this thing. No, you don't have to. Do you know any other different method? Even though you don't know the name, it's okay. No. The yellow one, please come outside. Fast, fast. I think I probably call her. Please come. So you both, what's your good name?
Anu.
Your good name?
Ruth.
Ruth. So here Anu and Ruth is here. Thank you for coming, by the way. So now, see, it's just a demonstration. I just want to correct you the method of evaluation. Okay, whatever you do, that's fine. So Ruth want to check extraocular motility of Anu. Ruth, how do you do? See, please take it very casual, okay? We are not having any exam here. आराम से करो, जो भी हो, आराम से करो. Come little forward, yeah. So what all you instruct the patient, Anu? Oh, sorry, Ruth. What all you instruct the patient before you check the EOM? What do you have to tell the patient?
ഹെഡ് മൂവ് ചെയ്യാണ്ട് നമ്മൾ കൊടുക്കുന്ന ടാർഗറ്റിലേക്ക് നോക്കാൻ പറയുക. എന്നിട്ട് അത് മൂവ് ചെയ്യുന്നതിനനുസരിച്ച് കണ്ണ് മാത്രം മൂവ് ചെയ്തിട്ട് അതിലോട്ട് നോക്കാമെന്ന് പറയുക.
So head move ചെയ്യാതെ എന്ന് പറയുമ്പോൾ, let's say you are checking mine. Okay, I am keeping my head like this. I still not move it. I'll keep it like this. Is that the right method? No. So we should keep it in a erect way. Yes, erect way. It's a straight one. Yeah. Now I think you can check on her.
Ask to see the end of the tip. Then
Positive? Yeah? So, when, okay, thank you so much. You both can sit. Thank you. Any, oh, yeah. Wait, come to that point. Both of you come outside. Come on fast, I don't have time. Come. So you checked, you have seen Ruth and Anu was performing. So always important to tell the patient to keep the eye erect right here. Erect, straight position. Okay, do not allow AHP. Yeah, if you allow AHP or eccentric fixation, it's not the accurate method to do it. It's a wrong estimation, by the way. So you're supposed to ask the patient to keep the eyes and the head in an erect, straight way. And then, why do you give a tip? You can ask them to even look at this. Why? Louder. Why do you need a point fixation? You're not checking convergence. Yeah. How does it make difference? Yeah. So why does that important here? So let me talk about convergence. Boys, please excuse me for a second. So when you talk about convergence, it's very important you need to have a single target. Yeah? So that's fair to say there. Why in broad edge test you will ask them to look at the tip? You can even do with torchlight. You know, right? Yeah. So you have two tasks today. You have to tell me why word for dot test me the targets are in diagonal. Second thing, why are you using, why you are telling pen ka tip while you check for the broad edge test. These two tasks. We'll meet after again lunch. Guys, come on. Whatever method you want, you can show. Yeah. Talk to the patient first. I'm sorry. See, these all are your friends, classmates, colleagues. Yeah? You don't have to be shy. You don't have to be perfect. Yeah? Do it very.
Straight നോക്കണം, ഹെഡ് മൂവ് ചെയ്യരുത്, ഈ പെന്നിൻ്റെ ടിപ്പിലേക്ക് തന്നെ നോക്കണം കേട്ടോ. ഹെഡ് മൂവ് ചെയ്യരുത്.
എക്സാമിനറിനെ അറിയുന്നില്ല എങ്ങനെയാ ചെയ്യേണ്ടതെന്ന്.
നേരെ നിൽക്കാതെയോ?
എന്നോട് നേരെ നിൽക്കാൻ. This is why I'm telling you have to be cooperative with the patient. The patient cannot cooperate with you.
പെന്നിൻ്റെ ടിപ്പിലേക്ക് നോക്കാം.
Don't laugh. They are very serious about it, okay? Yeah. So what is your findings? What is your findings? What do you get? Normal. What do you mean by normal? Does he look normal? Good. Thank you, both of you. Please, thank you. So basically, you have seen both people doing it. Now you can give a clap for both the team. Yeah. Yeah. So I see that backbenchers now. Yeah. All right. So you have, whose pen is this? Yours? Yeah. Thank you. So you saw two different methods of people doing it, right? So first of all, head position is always important. Patient is not allowed to move the head. Second thing, eye movement. You should track the eye movement. You should not look at him. You should look at his eyes. Okay? Whenever you check for it, you should actually look at the eyes. Only then you will understand whether there is a underaction, overaction, restriction, or whatever it is. Okay? Now, how do you denotify it? Safe. Oh my God, who said that? Give him a real big round of applause. Thank you. I really love it. I really love it. Good job. Oh, okay, by the way, chalo man, I don't have time for this. So basically, it's full and free. Okay, what you were saying about safe? S-A-F-E. Safe. Okay, I'm actually unaware about that, but basically the standard of saying is full, free. Okay, full and free. Okay, so this is how you are supposed to denotify it. Yeah, you have to draw the broad edge, and if there is any underaction, you should put a minus negative mark over there. If there is an overaction, put a plus mark over there. I've seen many people doing it, broad edge test mein, they will keep plus everywhere. So that might confuse you. Why? Yeah, so basically the person will be understood in the way that's normal. It's active all the place, but you don't have to denotify it anywhere. You have to just mention saying that full and free. Yeah, and then you have to, like, in case if there is any underaction, overaction, respectively, you have to mark it on the broad edge. Now, one more quick question: why do you not do it in a elevation and depression? There is no primary acted muscles. It's always secondary action of two different muscles. Okay, so that's the reason you have no any primary muscles to be checked over there. We won't check it in a elevation and depression. Okay, what are the 9 cardinal positions? Wait. Yeah. 1, yeah. 1, 1, 1 you can say. Elevation. Next one. Depression. Please sit, yeah. You don't have to stay in. It's okay, you can sit and say. Extro elevation, dextro elevation. Now, dextro depression. Levo elevation. Dextro elevation already said. Levo depression. Levo version. Okay, cardinal position. Next one. Dextro. Oh, yeah. Dextro what version? Yeah? I didn't get what you say. Versions. Okay, fine. So basically you have a conjugate versions movements over there, right? So extraocular muscles you are checking the 9 cardinal positions. Sorry, not 9 cardinal, except the elevation and the depression. Okay, so the dextro levo, and then adduction and abductions. So when you check broad edge test, will you check it binocularly or monocularly? Binocularly. How do you notify? Will you write only one edge or you will write both edge? One edge. You have to draw 2 edge. Basically you have to do 2 edge and then say about it. Although you are looking for actually it is always best to do it monocularly also. But it's very rarely practiced talking about a routine OPD. So even if you check binocularly, you should look at the movements of both the eyes. Okay, it's a conjugate movement. It's not a disjugate movement, right? So you should know whether both eyes are coordinating equally or not, and you have to mention it that way. Got it? Yeah. And yeah, also you have a different method. You are aware about it. Like broad edge is always standard. And whenever you move the pen, Let's say there is an examiner over here. You will always start from the primary gaze and the erect position. And then you will go to one point, then the other point, then come down, then the down one, then this one. Here when Anu, right? Anu did. The small correction I want to give you, Anu, because Anu took it down this way. You would never do it. Okay? Broad edge itself is the name indicates the direction you are supposed to pass the target. It's an edge. So you should not directly go to the other position. You have to come back and then come to the primary position, then go to this, then up, then center, then down. This has to be followed. Okay? Now, cover test. What is cover test? Thank you, man. Cover test, cover test. What do you basically do in cover test? Okay, you are basically breaking the fusion and understanding the phoria, tropia, heterophoria, whatever it is. So cover tests are many different types. What are the types? Cover and cover test, alternative cover test. हो गया? Okay, prism bar cover test. Then, so I'll tell you again. Cover and cover test, alternative cover test, prism bar cover test. Forget about prism bar. Coming to the cover test. Do you really think there is only two things? Cover test, cover and cover test, alternative cover test. So what do you mean by cover test then? Sorry dear.
So the movement of covered eye.
Covered eye. So what is actually called? It's not called cover test. Cover test is altogether, the name is cover test. It's called direct cover test. Okay, so direct cover test, cover and cover test, alternate cover test. So what do you do with the direct cover test? The first one at the last bench. Come on, man. We'll have some fun. Come. Anyway, you're bored there. Come. What's your good name?
Sudhi.
Yeah. Nice to meet you, Sudhi. I'm Arya, by the way. Yeah. Yes. So, hey, there is nothing to laugh. Okay. So, Sudhi, my dear friend. So, I'm going to check him and you have to tell me which method am I using there. So, we have three methods. One is direct. Second is cover and cover. Third is, can I hope you will not forget this? At least you will write in the exam paper about at least these three. Direct, cover and cover, alternate. Don't blabber in my class. If you say, it's okay. If you don't know, that is also okay. ठीक है? So, Sudhi, yeah. Sudhi, he is my patient and I'm going to make him stand across me. I'm sorry I do not have so much height, Sudhi. Yeah. So, what target are you going to give? What target are you giving? Torchlight? Forehead? Distance? Complicated. So basically forehead is a very less standard method. Okay, don't tell anybody to look at your forehead. Okay, for example, I have a lot of pimples on my forehead and one is here and one is here. With which one patient will look? Or if I have a bindi, patient might look at that bindi. If there is a person who does not have a bindi, where he will look? The whole forehead is a big one, man. Right? So always what do you give? So when you check, oh, this is your face. Great to see that again. I'm so sorry. I didn't realize you for some time. Yeah. So by the way, you might be sweat with the mask. It's okay. You can remove it. Nobody has corona so far. So it's good. So basically, when you... You okay now? Can I continue? Thank you. So, cover test can be done for distance and near. All three of it. So, what is the idea of doing at distance? without accommodation. Yeah? And what is the idea of doing it near? With active accommodation. Yeah? That's an active accommodation. So when you give a target, if you give a forehead, how do you know is the accommodation is active or not? Is that the real method to do? No. You should give a target. You should give a target, the patient will have a active accommodation. So give a target. It can be, oh, I'm sorry, I did not brought them with me. So basically there is a stick. You know, it's a fixation sticks comes, and that fixation stick has to be supposed to be shown in front of the patient, and then we will ask the patient to look at that. Just hold the mic for me. So, Sudhi, okay, I'm sorry, I cannot use all the hands together. So, Sudhi, you are supposed to, for example, sorry, I do not have the target with me. So, I'm just using the pretend to be, hypothetically, this is the target. Okay. Now, you are supposed to look at the target here. So, now do not squeeze your eyes, relax and normally look at the target. For example, look at this GL. So, look at the G. Looking at the target. You are reading it, right? Yeah. Whenever you give target, you have to ask the patient to actively accommodate. Yeah. So ask some activity. You know, give some activity target. Whenever you give it, do not give it horizontal way, because patient will have catchy movements. From one letter to another letter, they'll have a catchy movement. So it's always better to give it as a vertical one. Yeah. So Sudhi have to look at this. Now I'll call somebody. Yes, the glass one behind you. I'm sorry, I'm not knowing your name. Just behind you. Next to yellow. Next to yellow. Yes. Yes. No, be there, no problem. You just have to tell me which method am I using. Yeah? Sudhi, please look at this, okay? Just compromise. I do not have a chair. I'm so sorry. So I'm going to look at Sudhi. Tell me. Cover and cover. Then? Then? What is this now? Direct cover test. Okay. Now this one? That everybody knows. Okay, yeah. Thank you, Sudhi. By the way, you do not have any phobia. Please go. Thank you. Thank you. So, thank you, dear. Please sit. So, cover and cover test and direct cover test. What is the difference between this? You have a lot of confusion. Please use the mic and talk.
ഡയറക്റ്റ് കവർ ടെസ്റ്റിൽ നമ്മൾ പേഷ്യൻറ്റിനെ അൺകവേർഡ് ഐ ആണ് നോക്കുക. എനിക്കറിയുന്ന കാര്യം പറഞ്ഞു. കവർ ആൻഡ് അൺകവറിൽ നമ്മൾ ആ സെയിം ഐ ആണ് നോക്കുക. കവർ ചെയ്തിട്ട് ആ സെയിം നമ്മൾ കവർ ചെയ്യുന്ന ഐനെ നോക്കുക. ആൾട്ടർനേറ്റീവ് കവർ ടെസ്റ്റിൽ രണ്ട് കണ്ണ് മാറി മാറി നോക്കുക.
So, which one gives you idea about phobia? Sit, please sit. You guys are a lot confused about it. Please go back and read cover test again. So, phobia, what is phobia basically? So, let's say, look at me, just give me a target, come here. I don't know how many of you can see, but stand here, man. Give me the target. So, basically, I'm checking my eyes, okay? See, I'm closing one eye, removing it. How many of you can see my eye movements? Okay, it's a little tougher. Please come. I'll come back to you guys. Yeah, please. Now, I'm sorry to utilize you. Yeah. Now, just I'm closing one eye. What did you see? Do I have an eye movement? No. Sure? Okay. Yes. Actually, I have an eye movement. I'm phoric. Okay, please, thank you. I have an exophoria. So basically, when you check for it, when the target is given, when you check for it, the moment you cover the eye and then uncover the eye, you are looking the moment of covered eye, which means You're totally breaking what? Fusion. That eye is for some time, right? It's like cover, uncover, right? So this eye is taking place, which is actually phoria. Okay, the concepts has to be understood really well. And if you're covering, if this eye comes to the fixation or if this eye has a movement, it's counted as a tropia. Understood? So don't get confused of this. Whenever you practice, you'll have a lot of confusion. Just itna to samajh mein aana. You have to understand only so much. Ki when you close and then unclose, yeah, there will be a slight movement for this eye, which counted as a phoria. And the other one movement, tropia. Ho gaya? It's easy. Now, Maddox double row test. What is Maddox row test? Maddox row irikkunnundu edutittu va. So, Maddox row test. How do you do? Forget about double Maddox row test. Maddox row test. Who invented Maddox rod? Oh, wow. Okay, good. Arya, you did it. So, Maddox rod is, there is a striated red striped glasses. Yes, exactly. So, why do we use Maddox? To check what? Phoria, exactly. Good job. Thank you. So, I think most of you have seen Maddox, right? Yeah. This comes like this. One side will be plano and other side there is stripes over there. So why do these stripes matters? What does stripes do here? Yeah, I think she knows the answer. Please.
Spot of light നെ streak of light ആയിട്ട് convert ചെയ്യാനായിട്ട്.
Yes, and what do you get from that? Why it's important to do Maddox rod in that particular way?
ഫോറിയുടെ കറക്റ്റ് പൊസിഷനൊക്കെ അറിയാൻ വേണ്ടിയിട്ട് ഈസോ ആണ് എക്സോ ആണെന്നൊക്കെ.
Yes, create a dissociation basically. Yeah, so that's how Maddox rod works always. So how do you check Maddox rod? Yeah, torchlight you need to have. You'll keep the trial frame, then put it in front of the patient. So when you check vertical phoria, how do you keep this? Horizontally. And if it's a horizontal one? Oh my God, perfect. Yeah. Somebody is awake now. So that's how you check it here. So why phoria is specifically understood by Maddox rod? That's my question. Even when you check for this thing, fusion breaks there, right? Yeah. Why? Why phoria? Okay, lunch break me. You have now 3 questions. Okay, don't forget it. And yes, so Maddox rod you have to keep this one. For distance you will give a single target, linear target, and then what? We will ask the patient where the light and the line aligns. Accordingly we will decide whether it's an exo or iso, hypo or hyper. I don't want to go to the much complicated area of that. You already have it in the textbook. PPCT, prism bar cover test. And you know how to do prism bar cover test, right? For example, I have a patient here, prism bar. So, prism bar, if I am going to check on her, I can keep the prism bar in front of one eye, which I am supposed to cover. Should I use cover and cover method? Should I use alternate cover method? Cover and cover. Why? Exactly. So we, oh yeah, great. Open it, no? Yeah. So basically to check, oh yeah, there are 2 of it. Vertical, yeah. So what is this covered prism bar? Horizontal. And this one? Vertical. Okay. Okay. Although it's entertaining me, it's good. Until I limit, okay? Yeah. So this one you will keep in front of the eye. Yeah. Will you start from 40 or you will start from, this one is 1. Yeah. 1. Yeah. And whenever you move it, how do you move it? Will you allow the patient to blink? Okay, you do this examination for 2 minutes. Will you tell the patient that you should not blink for 2 minutes? The normal blinking is always allowed. Your patient is not supposed to be blink unnecessarily or intentionally, or the patient should not squeeze the eyes. That's the main motto of this. Okay? And whenever you move it, what is important, you have to always maintain the optic center to the center of the prism. Yeah? You should not interfere with the interference of these prisms. So what happens if you interfere? Already patient will start appreciating diplopia, and thus the alignment of the eye will be deviating. So it should be always a linear, gentle movement. You cannot just go like this. You have to be a gentle, linear movement. Give some time for the eye to adapt the prism, especially when it comes to the higher prisms. If all of a sudden you keep 25 and then do a cover test, it's not happening, and directly go to 30 prism, it's not going to be the way. You have to give a minimal adaptation time. Again, that doesn't mean 1 minute, 2 minutes you have to keep and wait for the patient. Okay? So everything just for the quantity. Now, AC by hair ratio. What are the methods to find AC by hair ratio? Heterophoria gradient, that's it. Yeah? Heterophoria gradient method, that's it. हो गया? Yeah, നാലെണ്ണം ഉണ്ട്. എന്താണ് നാലെണ്ണം എന്നാണ് ചോദ്യം. Haploscopic, then haploscopic, okay, I don't know about that. Okay, motor evaluation next covers cover test. Okay, we'll just talk about it. Ocular motility, basically we are checking for the ductions and versions. Now coming to near point of accommodation. How do you check near point of accommodation? RF ruler. Push-up test. Okay, then minus lens. Perfect. Can anyone come and say about minus lens? I think you said minus lens, right? Please explain. Use the mic.
മൈനസ് ലെൻസ് ഗ്രാജുവലി ഇൻക്രീസ് ചെയ്യുക, എന്നിട്ട് പേഷ്യൻറ്റ് ഫസ്റ്റ് സസ്റ്റൈനബിൾ ബ്ലർ.
So what does it mean? Basically, why do you use minus lens? To stimulate the accommodation. So basically when you please, thank you. So whenever you check for an NPA value, which means near point of accommodation, yeah, which is the maximal accommodation activated to see the closest object. Okay. Now when you check for an accommodation, NPA, let's say there is a target given to the patient. What would be the target, by the way? Okay. Tell me, near point of accommodation can be checked for distance and near? Did I ask any one of you? Can we check? Near point of accommodation. നിയറുള്ള പോയിന്റ് ആയിരുന്നു, അതുകൊണ്ടാണ് അടയ്ക്കാത്തത്. ഓക്കെ, യാ, യു ഹാവ് സം ബ്രെയിൻ. എനിവേ, ഗുഡ് ജോബ്, താങ്ക് യു. നോ, വെറുതെ ആട്ടം കണ്ട് കൈയടിക്കലാവരുതല്ലോ, എന്തെങ്കിലുമൊക്കെ അറിയണ്ടേ, അതിന് വേണ്ടിയിട്ടാണേ. സോ ഡോണ്ട് തിങ്ക് ഐ എം ടാർഗറ്റിംഗ് യു. സോ നിയർ പോയിന്റ് ഓഫ് അക്കോമഡേഷൻ ചെയ്യുമ്പോൾ യു ഹാവ് ടു മെഷർ ദ possible maximum accommodation exerted by the patient. Yeah. Now, you are checking for accommodation, NPA, and the patient is saying, yeah, it's blurred now. So what do you do now? The first blurred. Parnoda. Yeah, you will measure the distance, you mean to say. Yeah, and what else? What else? You should answer this question. I explained you that thing.
Once more. First blur, then ആദ്യം ബ്ലർ ആവുന്നതിന് ശേഷം ആ പോയിന്റ് ബ്രേക്ക് പോയിന്റ് കാരണം പിന്നെ ബ്ലർ ബ്രേക്ക്.
So my question is, what is your next course of action?
റിപ്പീറ്റ് ചെയ്ത് അത് നോട്ട് ചെയ്യും, ദെൻ റിപ്പീറ്റ് ചെയ്തിട്ട് ഒരു 3 times 5 times.
Thank you so much, by the way. Repeating binocular vision, evaluations are actually needs to be very careful. One point is that, like, once you keep stimulating the accommodation, the optimal mean accommodation whatever you have will fluctuate. So do not try to repeat it multiple times. Or if you really want to repeat it, give a break to the patient, because already the accommodation is active. The patient is more of target in the near, because most of these activities are actually near targeted things, all the assessment. So basically what we do, when the patient appreciate first blur point, we will make sure it is the last blur point or not. Sometime maybe because of patient is under a fan, or the patient is having dryness, or if it's very sunny that time or a winter that time, it depends on the patient's eye, might get dry, so that patient can see it as a blur. Yeah, or maybe the patient is a little sleepy or drowsy or something, and yeah, it's blurred. So whatever the reasons are behind it, you are supposed to ask the patient to blink the eyes. Yes, you're supposed to ask the patient to blink the eyes. Make sure not squeezing. Squeezing eye is different, blinking eye is different. It's a very common mistake we do it clinically. Yeah, we should not allow them to squeeze and see. Squeezing is something like this. That's not allowed. You are unnecessarily activating the stimulations. Yeah. Now what you have to do, you have to ask the patient to normally blink and see. If that is getting cleared again, you have to keep moving it further until the patient express persistent blurring. Persistent blurring, which means it never reverse. Yeah, whatever you have told us at 10 centimeter it was blur, after blinking it has reappeared, it has become clear. So this is always important to understand it. Okay, if let's say there is a very dry weather, if the patient is not very comfortable, drowsy or something, maybe they respond 20 centimeter itself is a blurry one. And blurring is not really subjectively measured. Objectively measured. We cannot say, yeah, the patient is really seeing blurry or not in accommodation. Convergence, we have methods to do that, but accommodation. Okay? So this is an accurate method. And whenever you do RAF ruler, again, both of you come here. Come, fast. You both. Da, poite RAF ruler edutittu va. Come fast. Why am I calling them? Because already they knew about it. Yeah. They had come. Very well. So they are going to check NPA. Just demonstratively do it. I do not want exact things. What's happening? There is a line going. You are assuming your own college. Yeah. So patient is supposed to keep it as a primary position, and then you have to keep the nose rest properly just on feet of your, just above the facial bones. Okay, just below the orbital bones. It should not cross the orbit, because it creates a pressure so that the values can change. Yeah. So what target you have to give? What target? N8. Is it always N8? Yes, exactly. So it's not always N8. Let's say I have N10 vision, but still I can check for my accommodation. It's not like I have no N8 vision, I cannot check it. I can still check N8. Near vision, near point of accommodation. It's always something like one line, yeah, lesser than the best corrected visual acuity. Yeah. You have to keep asking her, is she seeing blurry or not? Is it blur now? Now, please blink your eyes. Blink again. Is it clearing? Okay, so now the mistake is she doing here. Thank you so much, dear. I'll hold it, I need to put it. Can you please hold the mic for me? So now you have to do it yourself, okay, just I'm giving the demo. So in RAF ruler there will be 4 targets given. So except one, the rest 3 is supposed to be used for the accommodation. And how do you decide which target to be given? One is having N notation, one is having reduced Snellen, another is
General Post Office or telephone directory.
exactly. So according to the patient, you can actually use it. Okay. Let's say if a very aged person is coming and then asking him to read the N notations are not really fair. So it's your common sense basically. And then you will give a 1 line lesser than the best corrected visual acuity. So whenever you keep RAF ruler, that's where it's very important. That's what I told you. Position is always matters. When you keep it here, patient should not adjust. Yeah. The examiner has to adjust for the patient. Patient should be straight, looking straight, comfortably. Yeah. Now look at the second last line. Is it clear for you? Yeah. So before you start doing, make sure the patient is seeing the target already clear. Let's say the patient is already, the eye is dried or something and patient there itself started seeing blurry, then there is no point. And already checking it is like overactivated or underactivated accommodation. So make sure the patient is seeing very clearly, comfortably, then slowly start moving it. So you are actually keeping it parallel. You can see the RAF ruler. You are supposed to keep it as a parallel manner, okay? And then tell me when you start seeing it's blurry. Clear? Blur. Can you blink your eyes? Clear. Now? Blink. Blur. Blink. Blink again. Still blur. Now, this is the point you note as a blur point. Thank you so much, dear. You both can go and sit. So this is a point where you note as a blur point, where persistent blur happens. And this is supposed to be held parallelly. But when it comes to NPC, yeah, NPC, yes. Back. Why back? Why back? Why back? So basically, we are the target front, but we are taking the measurement of back. Why? What is the construction of RAF ruler? Huh? Okay, RAF ruler full form is yeah, Royal Air Force ruler. In the construction area, the way of style is this way. Why? See? Arila? Okay, just get it after lunch again. So we have 5 questions right now. Hoi, hoi, it's already broken. Yeah. So now, that's a very important question. Even I asked it when I was doing internship. It's a really good question. It's a really interesting answer although. I think you all yourself will find it out. It's a very simple question but very important yet. Now, when you check for NPC, so when you check for NPA, it's not about just you measure the blur point. So once you finish the blur point, bring it back and see where the patient started recovering and started seeing as a single one. So you have to write blur point and recovery point. That's always the standard method to write. Okay, and it is noted in what unit? Pardon me? Yes, you need to get the clear one now. Blur and clear. That's more important. Because there you will understand how much is the amplitude. Yeah, how much the intensity of that accommodation happens over there. Let's say the patient started seeing blur at 8 centimeter. That's a persistent point, okay? You got a blur point of 8 centimeter. And then you came to till 12 and still the patient is not seeing clear, which means there is something wrong with that response. This is very clear with this clear and blur and clear button. Basically, it's supposed to be within 1 to 2 centimeter of distance maximum. If it's overcrosses that, which means either you are doing wrong or the patient is responding more, or there is a root cause. Most probably, first two cases are there. Okay, either the patient is inappropriately responding to you. Now, when it comes to convergence, okay, unit of NPA. Centimeter, yeah. NPA and NPC both are measured in centimeter. Now convergence, NPC, near point of convergence. How do you check it? Say. I'll start there. The last one. She's like, oh, caught me. You good name? Afida. Afida, tell me, how do you check NPC?
ഡോട്ട് ഓൺലൈനിൽ ടാർജറ്റ് കൊടുക്കും. ഡബിളായി കാണുന്ന പോയിന്റ് പറയണം. മൈനസ് ലെൻസ് മെത്തേഡ്, പുഷപ്പ് മെത്തേഡ്.
So basically you can use red green goggles and a torchlight. Okay, so you have anything to discuss? Okay, Ruth is good. So Ruth, have you heard about red green goggles and pen torchlight to check for NPC? You know? Yes?
ഒരു കണ്ണിൽ റെഡ് ഫിൽറ്റർ വെക്കും, NPCക്കല്ല, എന്നിട്ട് ടോർച്ച് ലൈറ്റ് അടിക്കും. കളർ അടുത്തോട്ട് കൊണ്ടുവരുമ്പോൾ കളറിൽ എന്തെങ്കിലും രണ്ട് കളേഴ്സായിട്ട് വൈറ്റ് റെഡായിട്ട് സെപ്പറേറ്റ് ചെയ്യുന്നുണ്ടോ അതോ വ്യത്യാസം ഉണ്ടോ എന്ന് ചോദിക്കും പേഷ്യൻറ്റിനോട് ടോർച്ച് അടുത്തേക്ക് കൊണ്ടുവരുമ്പോൾ. എന്നിട്ട് ആ സെൻറ്റിമീറ്റർ നോട്ട് ചെയ്യും.
Thank you. By the way, you tried it well. So basically you have to use RAF ruler, you have a target, a line with a dot. So dot and line. Why do you have a line when you ask the patient to appreciate the double vision when the dot become double? Right? Will you ask the patient to say the double vision when the line become double? No. Sure? What is then line represents? What do line represents? Oh, thank you, dear. Don't touch. What do line represents? No, I have to keep it safe. Yeah. It's very close to my heart. So if you touch that, you're touching my heart. Yeah. You got it. Okay. Oh, I'm just joking. Okay, tell me now. Tell me. Why there is a line? ഇത് സത്യത്തിൽ രാമായണമൊക്കെ പഠിച്ചിരുന്ന് രാമനോട് സീത ആരാന്ന് ചോദിക്കണ പോലത്തെ അവസ്ഥയാണ്. റാഫ് റൂളർ എന്താണെന്നറിയാം, റെഡ് ഡോട്ട് എന്താണെന്നറിയാം, എങ്ങനെയാണ് NPC ചെക്ക് ചെയ്യണമെന്നറിയാം. ബട്ട് യു ഡോണ്ട് നോ വാട്ട് ഇസ് ദ ടാർഗറ്റ്. എനി ചാൻസ് യു നോ?
Physiological diplopia.
Please give her a clap. Yeah. Finally, some brain is working. Please stand up. I really appreciate it. Okay, so basically you have a dot and a line, and the line represents your physiological diplopia. Okay? And that gets double first. Okay? Blur, double, and then the dot gets become, double. So always physiological diplopia is normal. You know that, right? Right? Please don't tell you don't know. Physiological diplopia. It's normal. Yes, yeah. To keep the awareness, they have a target of line which represents the physiological diplopia. And the dot is the... What is dot? proximal tonic convergence, fusions. Okay, so that's how. So we are supposed to ask the patient when the dot become double. Last bench second aal. Come on. So when you keep the RAF ruler, when I keep the RAF ruler, you should check it. Okay. So Harris, you have to keep your head straight. I'm just demonstrating you all, and make sure you keep it in a proper bond manner. And the target is this, the dot with the line. Now, can you see this line? Yeah, do not shake your head. You have to always maintain the head posture. And then look at the dot. Is the line is clear? Dot is clear? It's a single and clear one, right? Perfect. Now, when you have to tell me when the dot become double. So you have to move it, very symmetric, uniform manner. And then, is it still single? Oh man, don't voluntarily make it double. Perfect. Yeah, even his eyes says that. Thank you. Thank you, Harris. Yeah. Thank you, Ria. So basically, what was the difference you found? Positioning of RAF ruler, very important. So why positioning of RAF ruler is important? Can anybody come and hold it on me? So basically when you check for NPA, you are checking for clearest vision, accommodation, which is quite active in all the, spaces. Now when it comes to convergence, is the convergence more active upper or lower? Lower. Why not upper? No, okay. So, can you give me? So, when you give a target on straight, let's say this is my primary gaze and I'm giving a target over here. So, I don't know how many people can see it. Basically, when I'm looking at the primary gaze, my eyes are already elevated. Yeah, my eyes are already elevated. And then once you start keeping it closer and closer and closer, still my elevation will very minute changes, not very big change, but slightly go up. Rather, if I keep it a little lower, still maintaining primary eye vision, primary position is still maintaining. You're not changing the cardinal position. Okay, you reduced a little bit lower down and then bring it. Then I have a very best activated maximum convergence. This is what important when you check for NPA and NPSA in RAF ruler as well as anything, doesn't matter. Yeah, when you give an exact primary position, you have something to ask? The next one to the right. Please raise your hands and ask me. Okay, yeah.
NPCയിൽ മാത്രമാണോ ഇത് ലോവർ ചെയ്ത് പിടിക്കേണ്ടത്? പക്ഷെ മാം പിടിച്ചപ്പോൾ ജസ്റ്റ് ഒരു ലോവർ ആയിട്ടാണ് ഫീൽ ചെയ്തത് NPA ചെയ്തപ്പോൾ.
I don't know, maybe I have done mistake. Do you everybody felt so? Was that lower? It's because of a RAF ruler is like that, man. I don't know, maybe if I have done, I pardon that. Apologize me. Basically, when you check for NPA, you are supposed to keep it straight. You have to be parallel. Yeah, so that's why when I immediately did NPA, I told you it has to be placed straight. Yeah, but when it comes to the convergence, when you check it in a primary position, what's happened? Already your eyes are little elevated. Yeah, and then once coming closer and closer, it makes a lot of uncomfort for the patient. Even though the convergence will be activated, that it makes it very bad and uncomfortable with the patients. Like they might feel already they'll have some irritation because they have to keep staring at one object. It makes them drowsy, dizziness and everything. So this is always a comfortable and accurate way. You have to keep it a little lower. But again, when you go to very much lower, the cardinal position is changing. Right? Already I'm in a depression. So there the question is important. When you check NPC, you're supposed to make it in a primary gaze with no elevation. Okay, so therefore keeping it little low, keeping the target little lower is always important. And one more reason, when you check this all with the glasses or, what do you call, trial sets, that itself will create a blockage over there. The width of that, the sector, the container, compartments will give a width over there. So when you keep it exactly on straight, even that interferes in the value of NPC. Again, NPC you have to find out where the patient have started finding it double. Again, ask the patient to blink and make it, if possible, make it single. If not, then that's your break point. Come back and find out where the patient is recovering it from double to single. These are the two values. Now, we were talking about this. Open. Yeah, so red-green goggles. Why do you wear red-green goggles? What is the basic idea of red-green goggles? Dissociation. It dissociates the eyes, right? So when it dissociates, what's actually happening? Fusion breakout. So my question is, you're actually checking in the maximum amount of fusion. Right? Yeah, right or not? When you check for a convergence, you're actually checking the fusion basically. Yeah, convergence, yeah. So when it's dissociated, what do you think, what makes sense doing a red-green goggles with the light? Yeah, I understood that idea. You're breaking the fusion, but you're already checking the fusion, right? You have to know the fusion. Yes. Yes. Yes, I understood that. So you are dissociating the eyes, you're separating the fusion, you're breaking the fusion, you're not allowing the normal fusion to be happen. Now, when you are checking for the maximum amount of convergence, when you know already the fusion is broken, what makes sense to do this evaluation? What makes sense? Anybody? Anybody? Working with plus lenses, you will keep and then remove. Yeah? Minus? Yeah, find it out, okay? I'm not going to explain it now, please. NRA and PRA. So negative, how do you notify them? How do you notify them? Lesser prism diopter to higher prism diopter. Do we do it distance and near? NRA, PRA, we are only doing it near. And NFE, PFE? Say it. Both, distance and near, both. Break point. Once the patient achieves the break point, you cannot increase the prism. Now you have to decrease and see where the patient recover it. So this you have to objectively and subjectively measure. Okay, you should also know whether the patient is saying correctly or not. So that you have to always look at the patient's eye, whether the patient's eye is getting deviated or not. If it's not deviated and still the patient is appreciating double, keep increasing it until you see it as a double. I mean the eyes are moving. And then come back to the recovery point when the eyes are going back to the aligned position. This is how you are doing NFE and PFE. Probably after lunch when we finish all of this, we might do it among us. So amplitude, fusional amplitude. So basically it includes NFE, PFE along with Fourier measurements. Okay, so that can be even Maddox Road or any of this. So, yeah, the discussion we'll do it in the last stage. Yeah. Yeah, so I think among all of you, maybe you also have a choice. Among all of you, you can decide which question who will see. Maybe it be something like in a bench there are 4 people, one person can answer one question, something like that. And I have 2 more topics to talk about today, and vision therapy probably will not be able to cover it today. Hope so, maybe I can come and meet you again for the vision therapy. I don't know, I'm not sure about it. So vision therapy I won't be covering so much. we will have a neurooptometry discussion and red flags in optometry because these are most important. Vision therapy you still see somewhere when you search around. So I think those two topics will cover it today itself. And after lunch, please be on time. Yeah?
Please come back at 2:30, okay? We are already delayed, so please take a half an hour and come back. Thank you. ബാക്കിലിരിക്കുന്നവർ ഈ ഫ്രണ്ടിലൊന്ന് കയറിയിരിക്കും. ഇവിടെ സീറ്റ് ഇങ്ങനെ എം ടി ആക്കിയിടരുത്, കയറിയിരിക്കും.
So shall we start? Yeah, everybody had lunch? Yummy? Yeah, so definitely again contributing to sleep. Yeah, hopefully I don't go for, very boring session like before one. It's always a dry subject, whatever I'm taking today. So whoever is not understanding or feeling is very not so, flow, please let me know. Please don't sleep. Okay, rather you can say that you are feeling sleepy. We'll try to engage it. Yeah? So we'll be discussing about red flags in optometry. So what is basically red flags? What do you mean by red flags? Yeah, tell me. I couldn't hear. Yeah.
In case danger.
So somewhere it's right. Whenever the red indicates, it comes out, it always indicates something danger. Please come. Yeah. So red flags in optometry. So there are a lot of red flags in ophthalmology. When you separate them differently, as an aspects of an optometrist, we have some red flags which we really have to, double cross or might have to do a further investigation optometric wise. Okay? So we'll be talking about it. So red flags is not something about danger, although it's about something you have to take another action for that. Let's say a patient who is coming just with a refractive problem, you can rather just do a refraction, please. You can rather do a refraction and prescribe the glasses and send the patient happily back home. Yeah, but when it comes to a red flags, for example, a patient who is having refractive error as well as a diplopia, will you be just doing the refraction and sending the patient? No. You have something extra estimated to be given to the patient or, to evaluate. Why don't you please come and fill here? Yeah. So that's how it is. Okay. It's not like about you have a dangerous situation in optometry. It's about how you have to be cautious about it. How you get the alert, when you have to be alert about the conditions. So there are n number of conditions you have to be really alert whenever you clinically attend a patient. Since it's a very basic level, I'm just talking only the basic levels of the red flags. So here we go. What is red flag? So I think you all understood it now. So red flag is not actually a danger. That's not about, we are not talking about what dangerous it is. It's about how you have to be alerted. Always you have to be alerted, activated, conscious about what you are doing and, to be present on what you do in a clinical manner. But when it has to be a red flags, which means you need something additional to do, just not the normal refractive workup. Alright? So alert, 4 things, which is a very basic thing, 4 of it. You can see first one is diplopia. Yeah? So diplopia, whenever it comes to a diplopia, as we always already discussed, diplopia, whenever the patient comes, you have a lot many changes in the normal routine OPD, from the OPDs, right? So it's like coming to history taking, visual acuity checking, as we discussed the pinhole, cover test. So many additional things are going to happen over there. So that's how diplopia is different. Headaches, basically. So when a patient comes with a headache, what all questions, what is the history you basically ask? So, okay, it's a position of headache, which place it's happening. So let me tell you, I'm a patient, I'm complaining like I have pain over here. So how do you denotify it? Bitemporal. So I think you guys are aware about it, yeah? So that position, okay? And second thing? Time, specific timing, yeah. Frequency and duration, yeah. So these all matters. Let's say a patient is coming to an OPD and saying that the morning when I wake up, I have a heavy and a huge headache. What is the first thing coming to your mind? Yeah, migraine then. It could be always pathological. This is what I want to say. It's not always optical related. It could be also a pathological, like migraine, sinus, whatever else. When a patient says in the morning is absolutely fine, once he starts working in the computer at the end of the day, he feels very tired and also hectic headache. Now, what comes into your mind? Yeah, it could be related to the near vision demanding task, whatever he is doing. And then it could be a lot related to the refractive error. So it changes there. Yeah. So headache, whenever a patient who has headache comes to us with an appropriate glass prescription, and then patient still complaining about headache, you can directly take the patient to an orthoptics clinic. If not, you are first supposed to correct the refractive correction completely, and then take a call on moral investigations. Okay. Then sudden loss of vision. What does it mean by sudden loss of vision? Yes, it could be pathological again, but when it can have a sudden loss of vision, when you have to talk about only optometry and orthoptics, what is the condition, specific condition, that sudden loss of vision? No, I'm just keep away the pathology. Yeah, I know glaucoma, there are lot many cases, right? Just about optometry. Yeah? I told you, forget about the pathology. Yeah? Apart from that, when you talk about the pure optics of the eye, anyone is aware about that, sudden loss of vision? No, opacity is not sudden loss of vision, right? Dislocation, again pathology. Trauma is pathology. So there is something called spasm of near reflex, complaining that suddenly he started having squint and he is not able to move around. So the deviation was always inside, the inward deviation, which was an esotropia. And suddenly he is not able to move around him, which means he is not able to see. So when we started measuring the visual acuity, he could perceive the light, perception was accurate, he could follow and fix them. But even finger counting, he was uncomfortable, but he could do it. So whereas coming to, spatial recognition, spatial awareness, even form visual acuity, he was not able to do it. Then it's very confusing. So what do you do in such cases? The near vision is absolutely not there. There is some residual or some hidden or else some veiled distance visual acuity. Basically it's veiled. There is a visual acuity because all these days he was absolutely normal. And all of a sudden he has gone blind. It's not really possible until unless there is no pathology. So how do you deal with such cases? How do you deal? You have a patient in front of you. 7 years. Younger age? Yeah? So what do you do? What do you do? Say? Yeah, so let's say there is no particular reason they could recollect. So examination wise you have to move forward, right? Whatever reason you collect, still examination wise you have to start it. Yeah, what do you do? First you have to do dynamic retinoscopy. You have to check the activity of accommodation. As a sudden onset of esotropia, your convergence is absolutely strong there. Along with that, accommodation is activated. Yeah, so you think something like this. Hypothetically, you never know about spasm of near reflex. So you're not aware of it. There is a patient who is sitting in front of you. So what you will do? So best thing always such cases comes, please measure the dynamic retinoscopy. So what is dynamic retinoscopy? Yeah, so we're actually checking the amount of accommodation activated during near vision task. Usually we will give them the target of light or bell or whatever it is. So we are actually checking the amount of accommodation activated at that particular moment. So you can actually understand what is happening there. So here two methods are there. Basically you can give that dynamic power as an add correction, give some trial time for the patient and call them back. If not, the best method is always use cycloplegic refraction. So this patient who has come to me is 7 years of age. So his vision was recordically it was something 20 by 200 hardly. So it was a very discomfortable vision for him. The form sensitivity was very less, and he was comfortable without light. Yeah. So with the light he had a lot of restrictions. He had huge sensitivity and many other issues. So here we go on checking for a cycloplegic refraction, where the result has come. The cycloplegic vision has become 6 by 18. 6 by 18. You did nothing there. You just dilated the patient. Okay, so why does there is a change of visual acuity? Yeah, it relaxed the accommodation. So it's something like, it's very easy. Like you have a normal vision, you put a huge amount of plus lenses in front of your eyes. What happens? You can understand, you have a spatial awareness, but you do not recognize it. You cannot move around confidently how you used to. Yeah, so this is what happens. So you relax the accommodation, which means you take out the plus lenses. Now you can see it clearly. It is not so easy to completely come back to the normal vision. It takes some time because it's about muscles and it's also sensory. So it takes some time. So always, whenever you get such situations, sudden onset of esotropia, there are exceptions. Example, if seizures. Okay, if there is a seizure, you should not do any of this. So that's why I told you there is no pathological reason the person can explain to us. So double cross it, okay? Or stroke or any new medication they have taken, no any other related thing, only ocular related problem. There you guide to be this way. Immediately dilate the patient, check the refraction. Before dilatation, after dilatation, refraction and visual acuity is important. Both are very important. So usually what happens when they come to us with the ESO deviation, they will have huge myopic correction, which will drastically change just after the cycloplegics. Okay, so this is how you are supposed to be managed. That's why I told you, sudden loss of vision can be also related to optometry, just with the, what I mean by optometry is the optics of the eye. Yeah? Epilepsy. So today I'll be more focusing about epilepsy, because this is something very new to us, I believe. How many of you is aware about epilepsy? How many of you? Epilepsy. What is epilepsy? Abasmaram. Yeah. In Malayalam, we say abasmaram. But actually, abasmaram is seizures. Yeah. So epilepsy is a seizure disorder. Epilepsy. Okay. So before that, listen. Those 4 are not only the cases. Okay. These are the basics of that cases. You have n number of red flags around you when you work in a normal OPD, but these are the basics of it. At least in this you should not miss out anything, because if we miss out something, there are a lot of changes happens in the management part. So always slit lamp examination. Posterior, anterior chamber examinations are always important. Now optometric evaluation includes pinhole test. Why pinhole test? Yeah, reduce the aberration, understand if the refractive error is present or not. Cover test, we already discussed. Ocular motility, important. Then near point of convergence, measurement of angle of deviation, please come. Prism cover test, Maddox double row test, Hess chart, diplopia chart. I'm sorry, I repeated that. Force reduction test. So Hess chart, diplopia chart. How many of you know about it? What is it? How do we do it? Anybody have heard diplopia chart and Hess chart? Yes, you learned about it, right? Everybody know about it, right? Yes, good. So, force reduction test. What is force reduction test? Yeah, to check the restriction of the particular eye muscle using the forceps. You will give a local anesthesia and then you will keep the forceps on the opposite side, and then you will pull to the other side. So you will understand if the eyeball is moving, then which means it has a real vulnerable alignment. If not, there is a restriction. You can measure it out. Quality wise, it's not a quantity measurement, although it's not really familiarly practiced with an optometrist nowadays. So optometric evaluation for headache. We already discussed this in the last slides. Why epilepsy? Why epilepsy is important? So basically, what is epilepsy? You know what is seizures? Fits, yeah, it's fits. So seizures, what is epilepsy basically? It's a brain disorder that causes recurring unprovoked seizures. So epilepsy and seizures are not same. So whenever a patient comes with a history of epilepsy or seizures, you should double check the factors, whatever you have to do in a normal OPD, as well as you have some subjective test to be done. Okay? So this is epilepsy. So what is epilepsy? It's a brain disorder that causes recurring unprovoked seizures. So seizures എന്താണെന്ന് എല്ലാവർക്കും മനസ്സിലായല്ലോ അല്ലേ? It's fits, അപസ്മാരം എന്നാണ് മലയാളത്തിൽ പറയാതിനെ. അതാണ് ഫിറ്റ്സ് അഥവാ സീഷേഴ്സ്. സോ അത് കോസ് ചെയ്യുന്ന ഒരു കണ്ടീഷനാണ് ആക്ച്വലി എപ്പിലെപ്സി. നൗ വൈ എപ്പിലെപ്സി ഫോർ അസ്? സോ സീഷേഴ്സ് എന്താണെന്ന് മനസ്സിലായോ? എല്ലാവർക്കും മനസ്സിലായി. സോ ബേസിക്കലി സീഷേഴ്സ് ആർ സഡൻ സർജ് ഓഫ് അബ്നോർമൽ എക്സസീവ് ഇലക്ട്രിക്കൽ ആക്ടിവിറ്റി ഇൻ യുവർ ബ്രെയിൻ. So basically, നമ്മുടെ body എല്ലാം, the whole body's mechanism is always have some electric activities to be done. So when it is excessively, projected to the brain, it troubles our system. So that condition is called as seizures. And then, why it is mattered for a optometry or an ophthalmology? Why does it matters to us? Because it's a brain always. So it's because there is something called eye seizures or ocular seizures. Okay, so what ocular seizures do? You can see in the picture, the kid is looking at one particular direction. Yeah? So this is how ocular seizures ocular seizures occurs basically. So all of a sudden, if they listen to some sound or if they get triggered of whatever causes they have, they'll start staring at one position like this, silently. Okay, usually kids look at different position because they might be daydreaming, so-called, I don't know. But when it has to be for a long time with the stiffness of eyes, okay, you can see in the picture, it's not like normally he is looking at that way. Yeah, so he has a strength of the eye. There is a stiffening around. So this is called eye seizures. Okay, so this is where, I'll tell you what is eye seizures. Yeah. If the seizures originates from the occipital lobe, so seizures originates from the brain itself basically. So we have, how many lobes are there in the brain? 4 lobes are there. And what is more important for eyes? Occipital, yeah. Although all 4 lobes participate in visual mechanism, occipital is the main one. So whenever a seizure emerges from the occipital lobe, that causes the ocular seizures. Video play చేయాలి. You want to ask something? No, good? Yeah. So, ocular seizures is always important because it can destroy a person from a normal seeing to a blind one. That severe it is. So basically, none of us are aware about much about this epilepsy. How much ever you go higher, how much ever you practice, there is no much information provided anywhere about this much. So basically, you don't have to go deeper or deeper, like until unless you're not into a neurooptometry or into in a specialized clinic, you just have to know the peripheral knowledge about the ocular epilepsy. So basically what happens whenever ocular seizures happens, or just in a normal epilepsy itself, there will be involuntary, uneven blinking rates. And they tend to close the eyes sometime, otherwise they try to blink it like this. Very involuntary. Or else sometimes they'll start rolling their eyes up. Complete, the cornea will go rolled up or rolled down. Most of the time it's rolled up. You'll completely roll up, you will only see the scleral part. So these are how the epilepsy present to the kids. And this is very common in awake? Yeah? Not you, that's yeah. Not ma'am, yeah. Okay, so I know it's very boring after lunch, everybody, and this topic is very boring too. It's very dry. I'm so sorry. But all the way. So when a patient who is having a history of epilepsy or seizures, you always have to ask them, how do the epilepsy present? Do there is a ocular symptom? Okay, because it restricts the ocular motility of the patient. It damages the sensory part of the baby. So you know, the developmental delay, the ocular developmental delay also happens once the baby is having any epilepsy or episodes of seizures. ഇതിന്ന് പ്ലേ ആവണില്ല അല്ലേ?
ഓൾറെഡി ഈ ഒരു വീഡിയോ ആ ഒരു ഫോൾഡർ ഏത് ഫയലിലുള്ള ഫോൾഡറിൽ ഉണ്ടെങ്കിൽ പ്ലേ ആവും.
ഓക്കെ,
ഓൾറെഡി ഹൈപ്പർ ലിങ്ക് കാര്യങ്ങളൊക്കെ കാണിക്കുന്നുണ്ട്, പക്ഷേ
മറ്റൊരു വേണില്ല സാറില്ല കിട്ടും. ഇറ്റ്സ് ഓക്കെ, നോ പ്രോബ്ലം. So basically, yeah, I'm sorry the video is not supporting on the system. So this is a kid less than 1 year of age, I believe. Yeah. Right now what he is having is actually ocular epilepsy. So you can see his posture. How does he is doing this? And look at the eye position. It's rolled up and it's straight. So once you see the video, actually he keeps the head straight and then he'll cycle with the legs. He'll keep move the legs, but the head will be straight and then he'll be rolling up and slowly he'll close the eyes. So this is how ocular epilepsy present all the time. So always ask whoever comes to a clinic with a complaint of seizures or past history of seizures, make sure there was no ocular epilepsy. If there was something, you should see ocular motility. Check for the ocular motility, stereopsis. If it's, the patient is adequate for the age, check for the stereopsis. And you should also check the sensory part of the eyes. Okay, separations, visual field. It's most important to check visual field for the kids who is having this kind of issues. So okay, what are the troubles they face? Basically in epilepsy they'll have fluctuation of vision. So when a patient who comes to you saying that a fluctuation of vision, make sure you ask them the history of seizures, whether they had it or not. Sometimes people does not realize there is a seizures. So we had a kid who was absolutely normal. He occasionally used to have some headache. Especially when he listens this evening voice, like he stays very close to the temple. So they keep that evening may they keep some song or chanting things. Whenever he listened to that, he'll get the seizures. I mean, he get the headaches, but he never knew that was a seizure. All of a sudden, he lost his vision and he came to us. Then we realized he had seizures running through for a long time. Okay, so always make sure the patient get communicated clearly and you rule out there itself. Yeah? Then visual field is very important because it always deals with your nerve system. So there are high chances the visual fields is not completely activated. So make sure you to check it. Sometime epilepsy along with the global developmental delay or specially abled kid, they comes to us. So checking the visual field with them, see, forget about visual field, checking the visual acuity itself is the biggest task. So just do a confrontation test. Just using a toy or any attractive objects. Even nowadays people use mobile or video games to just make sure that they are watching it out or not. So just, these are not necessary to do, but if you do this, there is a great changes in the management part. And you should ask for the writing skill. Sometimes they'll say school going kid ഇത്ര നാളും കുഴപ്പമൊന്നും ഉണ്ടായിരുന്നില്ല, സ്കൂളിൽ പോയിക്കൊണ്ടിരുന്നതാ, പെട്ടെന്ന് എന്താണെന്ന് അറിയില്ല, ഹീ സ്ലോലി സ്കൂളിൽ പോകാൻ ഇൻട്രസ്റ്റ് ഇല്ല, ഹീസ് നോട്ട് റീഡിങ് വെൽ, ഹീസ് ഹാവിങ് ട്രബിൾ ഇൻ റൈറ്റിംഗ്. You should also ask about the seizures in such cases. It's not always the kid is lazy. It's not always the kid does not want to study. Or it's not always the kid is trying to escape from you. There might be a hidden reason for all this. So this is very important to do. Then functional vision. So what is the difference between visual acuity and functional vision? What is the difference? Yeah, what activity? All right, so basically you have two factors, functional vision and visual functions. So when you get a vision with good quality, you should actually utilize it. That's what functional vision. How much ever visual acuity or the vision you have, are you really utilizing it? Are you really able to go through all the elements of it? That's what actually deals with the functional vision. Now cognitive vision. What is cognitive vision? What is cognition? Yeah, it's actually, exactly. So it's a brain eye activity. For example, if there is a water bottle here and it's kept like this. Now I'm telling her to just keep this one next to that, same like that. So if she is not understanding the position and where it is, what it is, she will not be able to keep it like this. So her cognition is active and if she is keeping like this. Let's say if she have kept it like this, which means her cognition has some trouble. Some people, it's very common, like I have one of my very close friends, he never remember the routes he travels. I mean, you know, almost every day we go in the route, still he don't remember it. Still he need a Google map to find it out, where to go, how to turn, which to take, which ride to take. This also deals with your cognitions. The things you remember, it's about visual memory, visual skills, you know, and then copying them. It's not just understanding, you can recreate it. Yeah, if I tell her just keep it parallelly like this, she can actually keep it like this also. But when she understands the top side is this, which means her cognition is active. That's what actually cognition skills. Oh, I'm sorry. Then ocular behavior. So there was a kid, I don't remember what is his age, very smart kid. Very, very smart kid. He ran around from here to there, he can read everything. More than 10 meters also, he's better than normal person. He never look at the face. He never look at the face. He'll be like, hi ma'am, how are you? But he'll directly give you the hands. He will never look at the hands, neither he look at the face, nothing. But he'll like, hi ma'am, how are you? He'll come, sometime he pinch the cheeks. He come and kiss us. But still he does not look at us. Never give an eye contact, never understand faces. How? So this is called visual behavior. He has 6x6 vision. Okay, complete normal vision. You check, you give him a target to read, he will read it absolutely normally. But he will not behave with the vision. He will never look at the eyes, but he can see it. So the reason is something else, but this is what called visual behavior. Yeah. No, he reads. Yeah, he reads. He'll like whatever comes as under his level, he'll read. He'll look at them and he'll do. And if it's a toy, if he's interested for him, he'll look at that. But when it comes to people, so basically it's not a problem. There is something called, you know, many things are there. There is a movie, I forgot that Amir Khan's movie, Dyslexia, Thare Zameen Par. So same thing. Those things are actually comes under same dyslexia, prosopagnosia, prognosias. So some people hesitate to understand face, like human face. It's because they never see us. So basically human face has got only 10% of contrast. Only 5 to 10% of contrast. Okay, so until unless you don't put a kajal, you don't put a big bindi, a dark lipstick, your eyes are less than a normal contrast. Okay, so when they do not have that, standard, they won't do it. And they will get used to do that. You can never correct them. They'll be normal, they'll be engineer, they'll be scientist, they might go to another, world itself, the galaxy itself, but they cannot do this. This is what it is. So this is what I mean by ocular behavior, okay? Yeah. So that's it about red flags in optometry. So I think diplopia, headache, and then what else we said? Yes. So those things are very common. So epilepsy is something we always miss it out, I feel like, and it is always new to somebody, and you have no articles, you have no particular subjects or books where you can read about the optometric impacts on it or ophthalmologic impacts on epilepsy kids. So always make sure these related things, whatever I told you, has to be overchecked. Now Chop Chop, tell me why Worth dot test has diagonal shape. Why don't we start from the last row? Just in front of Ashwati. Yeah. This one. Yeah. Hi. You were not there at the class, I think. She was there? Oh, miss, I'm sorry. I'm sorry about it. Yeah. No, even still she can answer. We'll start from here. Tell me why there is a diagonal. You can guess. See, I just don't want to come and sleep and tell something and you have to sleep here. Make it fun. Whatever you feel, why could be the reason, please tell me that. Yeah? Question. Who won the question once again? He. You. Three of you come. I'll explain the question. Please go stand in front of that. Come. Come. Let's not waste time. I have a lot more to discuss again. Please. So who is going to explain the question? Tell him what the question is.
എന്തുകൊണ്ടാണ് എന്താ പറയുക വെർഫോ ഡോട്ട് ടെസ്റ്റിന് നമ്മൾ ഡയഗണലായിട്ട് ഇതാക്കണമെന്നാണ് ചോദിച്ചത്, ആ ടാർഗറ്റ് കൊടുക്കണത്.
It will fusion for
the diagonal shape gives more
horizontal and vertical.
Horizontal and vertical? Yeah. Horizontal and vertical, what does it do? Yeah, no problem. അറിയില്ല എന്ന് ആരും പറയാൻ പറ്റില്ല. I'm asking what is your thought on it. I'm not asking what is the answer of it. Fusion. Do you also think it's fusion? Good. Just take it, relax. I want your thoughts on it, not the answer. Yeah.
Visual field. Visual field.
Visual field. Okay, you?
Fusion.
Speak in the mic, please.
Fusion.
Fusion.
ഡയഗണലായിട്ട് പ്ലേസ് ചെയ്യുമ്പം കുറച്ചുകൂടി ഡിസ്റ്റൻസിലല്ലേ പ്ലേസ് ചെയ്യുന്നത്? ഇപ്പോൾ സ്ക്വയർ ആണെങ്കിൽ അടുപ്പിച്ച്
Square ആയിട്ട് ഐഡന്റിഫൈ ചെയ്യാൻ
ആ
എക്സാമിനർക്ക് കറക്റ്റായിട്ട് അനലൈസ് ചെയ്യാൻ വേണ്ടിയിട്ട്.
എക്സാമിനർക്ക് കറക്റ്റ് അനലൈസ്.
അത് ഡിഫറൻഷ്യേറ്റ് ചെയ്ത് മനസ്സിലാക്കാൻ വേണ്ടിയിട്ട് എളുപ്പത്തിന് വേണ്ടിയിട്ടായിരിക്കും. അതായത് രണ്ട് ആ കളേഴ്സ് തമ്മിലുള്ള സ്പേസ് ഇട്ടേക്കണത് ഒരു ഡയഗണൽ ഷേപ്പ് ആയതുകൊണ്ട് എക്സാമിനർക്കാണെങ്കിലും അതായത് ഏത് കണ്ണാണ് ഈച്ച് മനസ്സിലാക്കാൻ വേണ്ടിയിട്ട്.
സപ്രഷനൊക്കെ ഡിപ്ലോപ്പിയും സപ്രഷനും ഡിഫറൻഷ്യേറ്റ് ചെയ്ത് മനസ്സിലാക്കാൻ വേണ്ടിയിട്ടാണ് ഡയഗണൽ യൂസ് ചെയ്യുക. സ്ക്വയറിലാകുമ്പോൾ ഒരു റോയിൽ തന്നെ രണ്ടെണ്ണം വരുമല്ലോ.
ഫ്യൂഷൻ മനസ്സിലാക്കാൻ.
It's about your thoughts. It's not a questionnaire. We're not having a viva here, okay? Nobody is judging you around because it's all your classmates, your colleagues around you, okay? You can share your thoughts on this.
മനസ്സിലാവാൻ വേണ്ടിയിട്ട്
What do you have to understand?
ഫ്യൂഷൻ.
Fusion.
ആ
Yeah, okay, here. Use it here.
വിഷ്വൽ ഫീൽഡ്.
Visual field. So basically, they're not checking visual field in work code autism. So,
സോ അത്
നിനക്ക് എന്താണോ നിന്റെ തോട്ട് എന്താണോ അത് പറഞ്ഞു. That's okay. Don't copy. It's okay.
വിഷ്വൽ ഫീൽഡ്
You think the visual field will be, elaborated?
Yes.
All right.
ഫ്യൂഷനായിട്ട് എക്സാമിനർക്ക് മനസ്സിലാക്കാൻ വേണ്ടിയിട്ട്
Fusion.
ഫ്യൂഷൻ പിന്നെ ഹൊറിസോണ്ടൽ വെർട്ടിക്കലി.
Okay. Go. രണ്ട് പറഞ്ഞത് നീയാണ് fine. No problem. So, anybody apart from this thoughts, anybody else have some suggestion? ഈ പറഞ്ഞതല്ലാതെ എന്തെങ്കിലും വേറെ തോട്ട്സ് ആരുടെയെങ്കിലും തലയിൽ ഉദിച്ചിട്ടുണ്ടോ?
ബാക്കി എല്ലാ ഷേപ്സ് നോക്കുകയാണെങ്കിൽ ഒന്നെങ്കിൽ കൺജസ്റ്റഡ് ആവും അല്ലെങ്കിൽ ഭയങ്കര സെപ്പറേഷൻസ് ഉണ്ടാവും. ഇതാകുമ്പോൾ ഒരു
എക്സ്ട്രാ ഓക്കുലർ മസിൽസിൻ്റെ പൊസിഷൻ.
There is nothing to deal with extraocular muscles. Anybody else?
ആ ഡ്രമ്മിലൊന്ന് കറക്റ്റ് സെറ്റ് ചെയ്യാൻ വേണ്ടിയിട്ട്.
Oh no, the drum can be set in even circle, square, rectangle. Okay, confusion, that's a good thought. Anybody else? I think now the teachers can participate. Who wants to contribute? I think she knows it. She's explaining to her student. Why don't you, what's your good name, ma'am? Afusha, yeah.
ഗൂഗിൾസ് വെച്ചിട്ടല്ലേ ചെയ്യുക. അപ്പം പേഷ്യൻറ്റിന് സ്ക്വയറോ ട്രയാങ്കിളോ കൊടുത്തു കഴിഞ്ഞാൽ പേഷ്യൻ്റ് 2 റെഡ് ഗ്രീൻ എന്ന് പറയുമ്പോൾ എക്സാമിനർക്കത് കൺഫ്യൂഷൻ. പിന്നെ സ്പേസ് കുറയ്ക്കാനാണോ?
So basically, yeah, thank you so much, ma'am. It was great. Yeah. So the thought about the confusion is absolutely right because it gives a lot of sense about it. But basic reason is none of this. So basically, it's about retina. The red, green corn cells have arranged in our retina as a diagonal shape. Yeah, thank you. Yeah, by the way, അങ്ങനെയാണ് സംഭവം. So basically, the red-green corn cells have arranged in your retina in that particular way. So rather, instead of giving a diagonal shape, you know, basically it's a triangular shape. And the diagonal one, why there is a concept of diagonal? Because there is one more white light coming. So the white light has to have equal reach from red as well as green. So that's always accurate to place the white one in the lower part. So it's because always it's related to the retina. I thought one person might will think about cons. Okay, no problem. That's good. By the way, thank you. Now what was our next question? Why do we use yellow light as a clinical? Why yellow light? Why not white light? Okay. So wavelength, yes, there is a difference. So whenever it comes to yellow, the point yellow is on the exact point of your fovea. Yeah? So if it's little backside, which color? Red or green? Green. A little front? Red. So the tendency of having misretinal correspondence will be reduced. Second thing, white light emits lot of blue oxygens. And it's harmful for the eyes. And it creates lot of sensitivity. So let's say you're checking a pupil. So when you have to check for a pupil reflex, if you have a very sensitive light in front of you, you might overestimate the patient's findings. Rather you have a yellow one, you will get the patient will be comfortable to view that. And then this is an exact point of it. Second thing is it's not harmful for the eyes. Very simple. What is our third question? RAF ruler. Why RAF ruler? So RAF ruler may we are keeping the target in the front, but we are taking the value of the backside bar. Why so? Yeah, let's share the thoughts on that.
പാരലായി വെച്ചിട്ടുണ്ടെങ്കിൽ കറക്റ്റായിട്ട് പറയാം.
കൺവെർജൻസും അക്കോമഡേഷനും കൂടി ഓക്കെ ആവാൻ വേണ്ടിയിട്ടാണ്, കറക്റ്റ് പോയിന്റ് കിട്ടാൻ വേണ്ടി. കൺവെർജൻസ് ആൻഡ് അക്കോമഡേഷൻ പോയിന്റ് കറക്റ്റ് എന്നുള്ള ആ ഒരു ഇതിനാണോ?
ക്വസ്റ്റ്യൻ ഒന്നും കൂടി പറയും. കറക്റ്റ് അക്യുറേറ്റ് ആയിട്ടുള്ളൊരു പവർ കിട്ടാനായിരുന്നു. ഞാനത് വിചാരിച്ചത് സത്യമായിട്ടും.
ഓക്കെ, ആർക്കാണ് കുറച്ച് വെറൈറ്റി ആയിട്ട് ചിന്തിക്കാൻ തോന്നുന്നത്?
നമ്മൾ RF വയ്ക്കുമ്പോൾ ചീക്ക് റെസ്റ്റും ഇതും തമ്മിലൊരു ഡിസ്റ്റൻസ് ഉണ്ടല്ലോ ഓൾറെഡി.
So that was the answer, very simple answer. ചക്കയുടെ മോല് ചത്താന്ന് മനസ്സിലായി. എന്നാൽ പോലും that's a great thought to have it way. So basically, RAF ruler, you are not keeping it on the right place, right? It's not touching you. you have a distance from the eyes to the beginning of that. And that distance is covered in your bar. Just get me that ref ruler. Good thought. Yeah, so that's why it is happening. Got it? Yeah, so you already lagging some distance from. So basically, RAF ruler in construction depended on it. So നമ്മൾ RAF ruler construct ചെയ്യുന്ന സമയത്ത് ഈ ഡിസ്റ്റൻസിനോട് ഈക്വൽ ആയിരിക്കണം ഇതിൻ്റെ ലെങ്ത് കൂടെ. Can you just hold the mic for me? Yeah. Thank you, Riya. So ഇവിടെ മുതൽ ഇതിൽ വരെ ഒരു ഡിസ്റ്റൻസ് കവർ ചെയ്യുന്നുണ്ട്. And it is not always necessary the nose has to be seated here. So this measurement and this measurement is always same. And always same, and thank you. So it's not always same. അങ്ങനെ ആയിരിക്കണം ഒരു റിയൽ RAF റൂളറിൻ്റെ ഒരു കൺസ്ട്രക്ഷൻ എന്ന് പറയുന്നത്. Okay, that's the reason നമ്മുടെ ടാർഗറ്റ് ഫ്രണ്ടിലാണെങ്കിലും we are taking the measurement from this area. Got it? Yeah. Thank you. Your good name? Amy. Oh, congratulations, Amy. You used some brain. Now, what was the next question? Maddox rodent में stripes. Why? Maddox rodent में stripes. വേറൊരു ക്വസ്റ്റ്യൻ കൂടി ഉണ്ടായിരുന്നില്ലേ? Yes. These two questions. We'll come back to that question. Now, before that, we will discuss some case here, okay? So, ഇവിടെ ഇരിക്കുന്ന എത്ര പേർക്ക് ഡിപ്ലോപ്പിയ ഹെയർ സ്റ്റാർട്ടിങ് ചെയ്യാൻ അറിയാം? ആർക്കും അറിയില്ല? ആർക്കും അറിയില്ല? തിയററ്റിക്കലി എല്ലാവരും പഠിച്ചിട്ടുണ്ടല്ലോ അല്ലേ? ഓ, ആരുടെയെങ്കിലും കയ്യിൽ റെറ്റിനോസ്കോപ്പ് ഉണ്ടോ? റെറ്റിനോസ്കോപ്പ്, ടോർച്ച് ലൈറ്റ് ഉണ്ടോ? Just give me. So, നമ്മൾ ഡിസ്കസ് ചെയ്യാൻ പോകുന്ന ഫസ്റ്റ് കേസ് ഇതാണ്. താങ്ക് യു ഡിയർ. സോ നമ്മൾ ഡിസ്കസ് ചെയ്യാൻ പോകുന്ന ഫസ്റ്റ് കേസ് ഇതാണ്. സോ കേസിലെ യു ക്യാൻ വാട്ട് ഹാപ്പൻ? All right. So, first case. So, it's a male, 23-year-old. Purpose was driving license evaluation. Yeah? There was no any ocular complaints present. Now, you have one more factor called uncorrected visual acuity was 6/6 in both the eyes and 6 at 35 centimeter in both the eyes. Yeah? Now, refraction is, there is a T here, okay? High plus correction basically. So, first action, of course. Now you have a patient, you took the history, there is no complaints, no other ocular related troubles they have complained, just came for a driving license evaluation, and then you found there is a high plus correction. Let's say it's more than +3. For a 23-year-old man, +3 is not a simple thing to do, right? Yeah? Don't think any high-end things. It's a very simple thing what I'm asking. Your first action of management, what would be that? So നമ്മുടെ മോർണിംഗ് ടോപ്പിക്കിൽ ആക്ച്വലി ഡിപ്ലോമ സ്റ്റുഡൻസ് ഉണ്ട് ഇവിടെ, BSc സ്റ്റുഡൻസ് ഉണ്ട്. സോ ഡിപ്ലോമ സ്റ്റുഡൻസ് മസ്റ്റ് നോട്ട് ബി അവെയർ മച്ച് അബൌട്ട് ഓർത്തോപ്റ്റിക്സ് ബൈനോക്കുലർ വിഷൻ. സോ അങ്ങനെ വിചാരിച്ച് ചെയ്യാൻ അങ്ങനെ ടോപ്പിക്കേ അല്ല ഇത്. ദ കേസ് ഡിസ്കഷൻസ് ആർ സപ്പോസ് ടു ബി യൂസ്ഫുൾ ഫോർ ഓൾ ഓഫ് us. So what would be the first action? How will you give glasses to this person? Varu. But vision normal aanalo. Latent hypermetropia thanne aanu sambhavam. But my question is, will you give glasses to this patient or not? Will you give glasses to this patient? No. You? Say yes or no. No. Will you give? You? 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 No. You? Just tell me yes or no. Will you give glasses? Yes. You? No. Yes. You? No. You? No. Tell me yes or no. There is no ocular complaints, no asthenopic symptom. Came for a driving license evaluation. You? No. How many of you say that you will give glasses? Please raise your hands. Okay, so now when you give glasses, under what criteria you will give glasses? Dilated refraction, okay. But in what point do you see there is a dilated refraction required? Because patient is having 6/6 vision, right? Okay, yeah. No, there is no any other asthenopic symptoms. Yeah. Yes, ma'am. You actually fog. Yeah. So you are supposed to give glasses to this patient. You have to give glasses. Because ഒരു 23 വയസ്സുള്ള ഒരു വ്യക്തിക്ക് +3 correction or more than, let's say, just forget about the number, higher plus correction ഉള്ള സമയത്ത് you have to give the glasses. Because myopia is easy to find. Because blurring vision എന്നുള്ളത് പെട്ടെന്ന് വരും അവർക്ക്. They will find it out faster. Hypermetropia, such cases like this, they will never understand it. Or there won't be any symptoms for them. But if you do not give them proper correction, what happens in future? The near vision? Early presbyopic. Yeah, they become early presbyopic. So here, how do you give glasses to this patient? Fogging. How do you fog the patient? ठीक है. Yes. So, basically, just common question. Let's say there is a patient who is having +3 diopter of hypermetropia in both the eyes. You are fogging the patient. Where do you start your fogging power? Where do you start your fogging power? +3. Why +6? So I can keep +7, right? Why not +7? Why not +4? There is a rule for that. We cannot just randomly start. You want to say something? Say. No. What the luck? Parayano noku.
Accommodation half.
Okay, it's not about accommodation, it's about the working distance. You have to add your working distance and then start the fogging. So let's say +3 aananundengil, you're supposed to start by +4.5. And if you want to give a strong fogging, ആ കേസിൽ ഇത് applicable ആണ്. You have to find out the amplitude of accommodation, add that power with the power whatever is there in the trial lens, and then start from that point. This is how you are supposed to fog. Okay, coming back to this case, now fogging is the method to do this. But how do you fog this patient? Will you compromise the vision? See, the thumb rule is not going to work here because patient is having best corrected visual acuity 6/6. So maximum plus is, we have to think about it actually. So fogging have to be done binocularly for this patient. The both eye has to be open. binocularly strong fogging has to be done for this patient. Okay, so you don't close the eyes. Binocularly you will give a target, binocularly you keep the fogging and then find it out. Okay, so this is how you do. So there is something called binocular fogging. When will you do binocular fogging? When there is a higher plus correction and then when the patient is not symptomatic. If there is asthenopic symptoms also, you can actually monocularly fog and give. That's okay. Okay actually. But if there is no any, sign or symptoms of complaints or no other ocular history or something, then in such cases, you are supposed to give a binocular fogging. And now next case is, there is a female of 28 years old, came for a follow-up, known case of IDS. What is IDS? IDS, intermittent divergent squint. Squint, strabismus എടുത്ത് കഴിഞ്ഞിട്ടില്ല നിങ്ങൾക്ക്? Start ചെയ്തിട്ടേ ഉള്ളൂ? Okay, so, then I don't think so this will help you. So just for example, in a future, in case if there is a patient who comes like this, forget about the age. Why I kept the age is because early age, IDS worsen cheyanalla chances actually comparatively koravaanu. So that's why 28 years of age, non-case of IDS, intermittent divergent squint, which means diverging squint. Yeah, so what you have to do here? It's a diverging squint. So what you have to do? You have to start making the eye to converge well. So IDS is a patient, just keep it in mind when you go for a practice. IDS is a patient, let's say they are coming and complaining you, there is a worsening of IDS. They are feeling like that. So IDS, it won't be always equal. Distance nearlum amount വ്യത്യാസം ഉണ്ടായിരിക്കും IDS. So in this case, patient IDS worsen ആവുന്നുണ്ട് and deviation കൂടുന്നതായി തോന്നുന്നുണ്ടെന്ന് പറയാണ്. So at such cases, what are you going to do? First thing, you are supposed to check stereopsis. So every time when the IDS worsens, or in many of these exotropic deviations, outward deviation, when each time when they worsen, the stereopsis come down. Okay, so this always keep in mind. I'm not going deeper then if you don't know about IDS. Yeah, the next case is 10 years old male, purpose was shaking of eyeball, no other complaints. Parents notice there is a shaking of eyeball. Okay, where complaints on there is no other complaints, absolutely. So my question is not what you are going to do. My question is, how do you check the patient's vision? So tell me first of all, what is shaking of eyeball? Nystagmus. How do you check the patient's vision? So basically, nystagmus is something simultaneous, coordinated movement of both the eyes. Right? Yeah. So when you close one eye, what happens? The frequency increases. It starts oscillating faster. Got it? It starts oscillating faster. So if you close one eye, whatever the real vision used to be there, even that disappears. Okay, so that's not fair. So what do? Have you ever heard of frosted occluders? No. So basically, translucent eye. A glass in the mela, frosted glass. I'm sorry, I couldn't get the picture. So there are some occluders, okay, which will have the light passes through it, but they cannot recognize what they are seeing. That's a basic classic method to do. You have to keep a frosted occluders in front of the eye, one of the eye, either of the eye, and check through the other eye. Once you finish this eye, you have to close this eye. So it still increases the frequency of nystagmus, but when you close completely, there is no light passing through it. So the frequency will be very faster. It's become very faster, and it reduces it underestimates the visual acuity from the normal one. So here you have to use the frosted glasses. Or if you do not have it, everybody is not available with such things. So what you have to do? You can keep a higher plus number. Higher plus number. Any of it randomly, just plus 10, plus 15, something like that you keep. Still the light is passing through it, but they cannot see it clearly. This is how it works. Okay? So nystagmus, whenever you check the vision, You should not occlude the eye completely. You should always use a translucent material to occlude the either of the eye. And then when it comes to refraction, how do you do refraction? Retinoscopy. How do you do? So here there is something called null point. Yeah, you know what is null point, right? What is null point? Just behind you. Caller. Yeah, what is null point, dear? Stand up. Quick, fast.
Neutralizing point.
Neutralizing point of what?
Movement reflects.
Null point in nystagmus I'm asking actually.
The shaking, when the shaking stop.
So the intensity of the shaking is lesser and the eye could focus better and make a better image in the brain. This point is called null point. So null point is not necessary always the patient will have in a primary gaze. There will be always AHP present, abnormal head postures or eccentric fixations. So usually when you have a patient coming to you, like you have to keep the head straight, erect, and then ask the patient to look at the target. Here you don't have to do that. Okay, so you can allow the patient to be in eccentric fixation or whatever, in the null point. So automatically patient will acquire, when you start checking the vision, patient will acquire the null point. Only then they can give the best visual acuity and comfortable visual acuity. So they will automatically turn to that particular point and you have to do refraction in that position. Alright, so whenever an nystagmus patient comes, you have to take care of two things. While checking vision, you have to give a translucent media to occlude. And then second one, when you do refraction, exactly, allow the null point and then do the refraction in that position. So that is what. Now another female with 18 years old age, outward deviation of eyes, manifest deviation. It's a manifest deviation. Exotropia, yeah. How do you check her vision? Yeah. Yeah, you can check it normally. There is no method. You have to check it normally. Just close one eye, then other eye will take fixation. Yeah. When you do this, only one thing you have to be clear or you have to be precise about. Just close, take the vision. Do not directly go to this eye and start checking this eye. Give some time for this eye to fixate back to the fovea. You know, might be the eye is already on the central part, but we don't know what's happening with the retina. So give some time for the patient. Now, how do you do refraction? That's what my question here. How do you do refraction? What special method you have got to do here? Or what extra you have to add here? No prism? No. High plus lens no. It's worsens that, right? Exotropy it is. No, what is the need of putting high plus lenses? No, no significance of that. No, forget about significance, there is no indication at all. So basically what you have to do when there is a manifest squint, irrespective of the deviation, okay, either of it, you have to close one eye while doing retinoscopy. You have to close one eye, do retinoscopy for the other eye, and then close this eye and do for the other eye. That's how you are supposed to do for a manifest squint. Okay, otherwise you won't get a real refractive error. Okay. So basically you have to occlude one eye, that's it. Whatever, so we have discussing about the outward deviation, which means exotropia, but actually it's the same case. Now there is a 30-year-old male, complaint was headache, no ocular complaints, allergic to mediatrix. We already discussed about it.
Boorish delay.
So 30-year-old, complaint was headache, No ocular other no complaints. Allergic to mediatrix as well as, yeah, mediatrix allergic kana. So you can't even use cycloplegic because that itself has got a mediatric quadrature. So what you have to do? You have to dilate and give because it's a headache case. Yeah, and it's a plus correction, I believe. Yeah. So what do you have to do? No, it's boorish delay. Yeah, you have to practice boorish delay and then give the glasses. Okay, boorish delay, immediately after boorish delay you cannot give glasses. You have always have to give a trial and error, and then give the glasses. See, even same like that, like when we did a binocular fogging, maybe when you binocularly fog, the patient might say like, oh, maybe 6/6 is not that clear. But you strongly feel that no, it should not reduce more than this, the plus correction. So what you got to do is that you have to give some time for the patient, give the trial lenses, give some material to read. If it's a plus correction, read. Ask the patient to go outside, expose it, explore it, and then start reading the reading materials in a closer distance and call the patient back after half an hour and check the vision. If the patient sees 6/6 clear by that time, which means your power is appropriate, then you can finalize the glass prescription. Do not hurry in such cases, okay, to give the glasses. Now, 28-year female came for a follow-up. Okay, we already discussed about it. Now, these are some exceptions. Overcorrected myopia and near vision. So what happens in these cases? There is a patient who is coming to you and telling you that my near vision has completely gone, or I'm not feeling comfortable to read like how I used to read after I wear these glasses. But the glasses will be only for distance. So if there is a myopic correction, let's say the patient had only -2.5. Now, before talking to them about this, always minus power people, myopic people, will tend to have extra. How much ever, like നാടൻ ഭാഷയിൽ പറഞ്ഞാൽ കൈക്കോട്ടിൻ്റെ സ്വഭാവമാണ് മയോപ്പിയയ്ക്ക്. എത്ര കിട്ടിയാലും മേടിച്ചുകൊണ്ടിരിക്കും. Yeah, I know you can relate it. Yeah, so myopia, even if you don't have any refractive correction, you keep -1 in front of them, they'll be still, yeah, wow, I can see everything clearer. It makes more clearer and clearer and clearer. Why? It activates accommodation. It's contributing extra power inside. So basically, because of this reason, myopic correction needs to be cross-verified always, thoroughly. Okay, so whenever you give a myopic correction, make sure you give a right amount of myopia. Do not overcorrect, do not undercorrect. It depends on the cases again too. So myopic correction, whenever you overcorrect it. So let's say -2.5, retinoscope, okay, always retinoscope, undilated retinoscope of myopia, you will always get an overestimation. So even after dilatation, sometime you might see, like, let's say there is a rush OPD, you couldn't manage to get the real accommodative value, you know, the proper myopic value. You have to manage to give the glasses. So make sure the patient is responding well to the diochrome test. Okay, so if the diochrome test, they respond very well, which means you are satisfied with. So minimal power may, how much best vision they can get without compromising the visual acuity, that's your myopic correction. So whenever you give a myopic correction, there are always a higher chance of overcorrecting. So when you overcorrect the myopic correction, what happens? So they'll start exerting accommodation, and slowly what happens? Yeah, it starts relaxing. Overexertion of it. You know, എന്ത് വസ്തുവാണ് നമ്മൾ കൂടുതൽ ടൈം ഒരു മെഷീൻ ഉപയോഗിക്കേണ്ട ടൈമിങ്ങിനും കൂടുതൽ നിങ്ങൾ അത് ഉപയോഗിച്ച് കഴിഞ്ഞാൽ it damages. It's the same thing. So that's one case when the patient is complaining of near vision, whoever is having myopia, always make sure there is an optimal correction, not undercorrected nor overcorrected. Here, sudden onset of esotropia, we already discussed about it. What is sudden onset of esotropia? What case we discussed? Spasm of near reflex. Dynamic retinoscopy. Why dynamic retinoscopy is important? Yeah, so basically dynamic retinoscopy important in special kids. Okay, because most of the globally developmental delayed kids will have extra accommodation always active in their eyes. Okay, and then cases like who cannot put drops and check. So basically, if there is allergy or if they says there is situation that they cannot go for a dynamic dilated refraction, check for a distance one, dry one, and then check for the dynamic, understand how much is accommodation activated, then subtract from the main value, give the glasses. So I don't know how much is going to be practically applied for all of you, but just keep in mind if at all you can. So thumb rule is maximum plus minimum minus. Exceptions are there. Okay. Amblyopia, strabismus, binocular vision anomalies. Okay. Amblyopia, strabismus, binocular vision anomalies. So this is the case discussion. Anybody has any doubt about this? Yeah? Somebody said yeah? Varkaunilla. So, well, our next topic is neurooptometry. Before going to that, it takes some time to open it all the way. So, tell. What was saying? We had some questions, right? Medox rod. And other one? Minus lenses, yeah. Let's start answering again. Who want to answer? We asked them. Yeah. Why do we not focus same as plus correction in minus lenses? In PRA.
PRAയിൽ മൈനസ് ലെൻസ് ആണ് നമ്മൾ ആഡ് ചെയ്ത് കൊടുക്കുന്നത്. മൈനസ് ലെൻസ് ഫസ്റ്റ് ആഡ് ചെയ്തിട്ട് അടുത്ത ലെൻസ് ഇടുന്നതിന് മുന്നേ തന്നെ അത് എടുക്കുക. കാരണം എന്താ വെച്ചാൽ അക്കോമഡേഷൻ ആക്റ്റീവ് ആവുന്നില്ലല്ലോ. അക്കോമഡേഷൻ ആക്റ്റീവ് ആയാലും കുഴപ്പമില്ലാത്തതുകൊണ്ട് മറ്റേതിൻ്റെ പോലെ ചെയ്യേണ്ട ആവശ്യമില്ല.
Your good name? Asna. Okay. So that's a great answer, Asna. You had some brain there. Yeah. So when you check for a positive, PRA, you need maximum of accommodation to be activated. So you don't have to get bothered. Okay, once if I take the plus lens out or the lens out, maybe the accommodation will start activating. We need that to be activated. We are checking the activated accommodation. So it doesn't count there. That's why it has to be done in this particular way. Okay? So now we have a next topic called meet. How many of you heard about neurooptometry? How many of you heard about neurooptometry? None of you. Boys, come up. All three of you. Boys I call, boys. Yeah. So what is neurooptometry? Because you all three are very energetic, right? It's not fair to call girls. They're very tired. Yeah, good. Thank you. So what is neurooptometry? How many of you heard about neurooptometry? Brain and eye connection. Yeah. What do you know about neurooptometry? Yes. So brain and eye, that's, neuro, obviously we know neurooptometry. How do you give a shake hand? You give like this. So you feel it's tight? No, it's loose. Can you tighten it? Yeah, like this. Oh. Can you give me a shake hand? Yeah. So it's loose. Yeah. Can you try giving me shake hand in the cross way? You feel comfortable? No. Yes? No. Okay. When you give shake hand, we usually give it like this. Yeah? Please come and forward. We usually give it like this. You come here. The orange one. Come. Fast. Yeah. When I give her, come this way. When I give her shake hand, I feel it smooth, well synced. Okay? rather when I give shake hand to him, this guy, it's huge, very uncomfortable. Yeah? All right. So when I give to her, and when we try cross, give me like this, cross shake hand, it still feel comfortable. Now you are okay to stay here, right? Yeah. Now what you have to understand, my hand is eyes, they are the brains. Okay, so the shake hand does not feel well, then you are uncomfortable. You will not continue it for a long time. Let's say he gave me, yeah, when he started pressing it over, I got pain, I withdrawed it. Yeah, when he gave, he said it's uncomfortable and it's not sinking well because he has got very motu wala hands. Yeah, and mine is patlu, so it doesn't go. And this looks very uncomfortable because it's very big and very dry, although, yeah. Alright? But rather I go and choose her, this is a soft one and it well synced to me. So which means I'm comfortable. So I choose this brain. Can I choose this brain? Yeah. Thank you. No, see, it's not about this thing. Okay, don't take it in a wrong way. I wanted to show because boys have a bigger hands and theirs is not really synced to us. So it has to have a propagations, a well maintained propagation. Yeah. Whoever has to leave, please leave. Don't miss your train. Thank you. Thank you. You're welcome. Thank you. So this is how it works. If the brain and go back. Thank you, dear. So it's not about their hands are bad. It's simple that it's not fitting with me. Okay, rather it fits with me, this is better. So meet neurooptometry. If it doesn't meet, like when you meet somebody, you need to give a good firm shake hand. If that doesn't happen well, it's there itself is discomfortable for you. So that's how brain and eye works. The brain gives, eye gives information to the brain and brain receives that. And sometimes brain passes the results to out of it. If this is not working synced, coordinated, then they'll stop working together. Brain will be brain apna jagah, eye will be apna jagah. രണ്ടുപേരുടെ വഴിക്ക് പോകും. So ഇതാണ് basic neurooptometry നമ്മൾ സംസാരിക്കുന്നതായിട്ടുള്ള കാര്യങ്ങൾ. So acknowledgement, I have no financial any disclosure with any of these commitments. Now, I really wanted to play this video, but unfortunately this is not happening here. Okay, leave it. So, in our brain, we have 4 lobes. What are the lobes? Exactly. So, occipital, frontal, parietal, and temporal. So, basically, occipital is most important for the eyes. That's what we know. But when you talk about neurooptometry, all 4 lobes are related to our visual mechanism. We need all 4 of them equally activated. Then you need to know only 2 things. We discussed about ambient and focal vision. Yeah? What is the object and where is the object? This is what we talk about, ambient and focal vision. So here you have a what pathway and where pathway. Why this ambient vision is happening? Why? Because there is something called what pathway processing in the brain, in the ventricle stream, and there is a dorsal stream. You just have to understand only this much, since you are very young to understand so much deeper inside. 2 things, ambient vision always corresponds to the what pathway. Focal vision always corresponds to the where pathway. These are done by the 4 lobes together. Brain uses 4 lobes together. Okay, so whenever it comes to the brain, the 4 lobes are always important. It's not just about occipital lobe. So this is about American Optometry Association, what they say is about neurooptometry. So talking about the history, basically this concept has been found by 1990. Okay, so it's just, it is not even actually a concept. The people started thinking about it. Again, it's because of the World War, and there was somebody, Phineas P. Gage, who have severely damaged his brain after the war. And then he had to live with that injury for 12 years, forgetting his whole past, but being a new man. He was totally a new man. With all other physical injury he had, but he still survived for 12 years. This is where the history of, or the concept of neuro-ophthalmology or neuro-optometry starts. Who is neuro-optometrist? Simple. Who practices the neuro-optometry and give a neuro-rehabilitation is a neuro-optometrist. So here, before studying neuro-optometry, we should know all these questions. What are the questions? First one, who should have neuro-optometric assessment? Who need it? Yeah? We cannot randomly give to everyone, right? This, just come, I'll do a neuro-optometry assessment. No, we cannot do it. So who need it? Why they need it? What you test there? When should you check that? What is the treatment? Only this much thing we'll discuss. Why have a neuro-optometric assessment? Why? Why is it important? So this is very unlikely to be identified. So now you got to know who is neuro-optometrist. Who deals with the binocular vision, who deals with the traumatic brain injuries, who deals with the globe assessment. Then these are some symptoms that they occur with fluctuating vision. Fluctuating vision is also present in some retinal diseases, so except that I am speaking about. Increasing difficulties wearing, it's very difficult again. Eye strain, discomfort, visual fatigue, balance difficulties. Now, what all we do here? What all we do? Yeah. Yes. So we check visual field. Most of these neuro-optometric cases, visual fields are always affected. And the pupil. What is a classic outcome or sign you can see in a traumatic brain injury? RAPD, exactly. Okay, let's say there is a patient who is sitting in front of you, traumatic brain injury, or they went through it, but there was no any visible injuries or something. But later on they start developing diminishing of vision or fluctuating of vision and coming to you, how much ever power you try to give them, they will not improve the vision. So here the first thing you can check for is pupillary reflex. If there is a RAPD present, there is no time or there is no point of giving a refractive correction to that patient, just keeping waste on time. Rather you have to refer to a neurologist, neuro-ophthalmologist basically. So that's very important. So RAPD will be always present in most of the neurological cases. And then ocular tracking. Some people, whoever have done like stroke, post-stroke, patient will come to you post-stroke and then again traumatic brain injury, cardiovascular arrest. They will have restriction in ocular motility. They will be trying to look at they'll be seeing but they cannot move the eyes. So this is most valuably evaluated. Then fusion ocular health, then ocular postures, resting postures. Okay, sometimes you can see when some patient comes to you and when they blink, one eye will be on normal position, the other eye will take long time to come and settle back. These all are related to the neuro-optometry. Then versions, visual acuity, processing speed. So these patients you definitely have to understand. So sometimes we'll get confused with optometry assessments, neuro-optometry aspects. Visual perception. What is visual perception? Perception of the images and objects in a space. Yeah. Then dilated fundus examination. Yeah, that's very important always. Now this is one of the instrument called Leah Vant. Yeah, I know you have seen that. Yeah, so Leah Vant. So basically, this does not quantify any of the visual field. So she is Miss Leah Haverian. You might have heard about Leah puzzles when you read about pediatric optometry. Yeah, you know Leah puzzles, right? Leah charts. Yeah, so she's the one who invented that. So this is again, it's her invention, this instrument as well. She will start showing the lights from the behind, and then she'll start showing in different positions, different intensities. And she will check it with the light, without light. This is the procedure of it. And then you will understand which point the patient is looking at and which point the patient is not looking. So it's just a quality measurement. It's not about quantity. Always quantity measurement in special need kids or traumatic brain injury is not really possible. So this is usually, the basic method is this. So I used kids picture because I worked in a pediatric department most of the time. And this is called mailbox. It's mailbox. What you have to do, you have a white card and a yellow card, developmental delay, sitting in front of you. You have to decide when to do a neurooptometric evaluation, a proper assessment. When did you decide that? What is the point you understand there is a need of a neurooptometric assessment? So basically, early in the recovery process, let's say there is a traumatic brain injury patient or a seizure epilepsy patient. So at the moment the patient recovered from the pathology, like the injuries and everything settled, early recovery point is the peak time to start an assessment. And then determine the integrity of the visual system. Just check for the integrity, how much strong is that visual system. Accordingly you can decide, like we can wait for some time or immediately we have to check for it. And then next point is visual system deficiencies. You have to accurately diagnose, such as color vision. Sometimes patients who is having steroids, and even at this. So this is about visual system deficiencies. You have to understand what are the deficiencies of that eye, and then if it's very severe, immediately start assessing. If not, let's decide on it. Can we take a call later or not? Then, if there is a patient who you feel that might need a rehabilitative approach, it is always important to start earliest. If there is no hope at all, if you find, okay, might have to go for a low vision aid, then so these are the small things I want to show, very basic thing. So neurooptometry is a very dry, deserted topic. Trust me, it's not at all interested when you talk about it. But when you do it, it's very interesting. You have a lot more things to do. You can implement your own investigation. You can implement your own therapies. You can develop your own system to do a patient. It's very entertaining. It's extreme challenging. Okay? So just want to tell you, it's very small exercises. Maybe in an OPD you do not have a high-end instruments or something, but still if you can, have this idea about these therapies, you might can help the patient that way. So there is a patient who is having eye-hand coordination. Let's say parents are coming and telling you, okay, my child is not actually able to copy, he is very slow from copying board. That could be a reason he is not able to see and then copy from the board at a time. The speed is not happening. That could be a reason of an eye-hand coordination delay. So such kids, you can actually use this method. It's very simple. There is a stick and there is pebbles. That's actually cornflakes, cornflakes, right? Yeah, people who is, yeah. So it's actually kind of a snack for kids. You're supposed to dip in the milk and eat. So that one has got a very undefined hole. It's a very undefined hole because each one will have different shapes. Although it's a round one, it's undefined. So patient do not have to by heart it. Kids are very smart. Even though they are special kids, they are very smart. They'll adapting faster. So when it's undefined one, they will not understand how exactly they have to keep. So basically they have to use the brain, activate their convergence and then put it inside. This helps even at convergence exercises. You can actually implement these activities. Like if you go and tell a patient to do a rock string for half an hour of 3 years of age, they will never do it. Rather you can practice something like this. And there is actually a light box and there is a black line striped over there. Why it's important? To make awareness, spatial awareness. If you give a rather huge amount of light, it's difficult for a person to understand what is the spatial awareness of space in that. So basically, when you keep these stripes on top of it, what happens, they'll really define them and it's easy for them to process it off. Now, these are called prism therapies. So when that kid had, a down gateways, always look down. Okay, so we initially thought she must be having some neck problem because she's a global developmental delayed kid, CVI kid, cerebral visual impairment. So we always thought there is a physical structure restricting her to look up. But later on, once the age she reached to check the visual fields, we found she does not have any visual field on around properly. So once you start deviating her visual field from here to here, she slowly started looking up. So this is how prism therapy works, shifting the fields. Now that's called pegboard. So it's keep rotating, there will be numbers given and there will be pegs given to the patient and we will instruct the patient. The patient has to listen to us, use the hand, use the sense and then keep it inside it. So it's multitasking basically. So these are a few other methods. So basically, what is the aim of treatment? Why do you treat a neurooptometry patient? What should be your main aims? Yes. So it is not always necessary that, let's say, 1 counting finger, 1 meter counting finger person can come to 6 by 60 or 6 by 6. It's never possible. Never guaranteed for this. Okay. Rather, what are we doing? Whatever residual vision they have, we are enhancing them and trying to utilize it. Let's say there is a person who is having 1 meter distance vision. If you keep him sit over there, he will just sit there. Whatever vision he is, residual vision is present, even that he will not be, able to use or he will never try to use it. Rather, you start enhancing it. In that 1 meter of distance, how much field he can see, how much activity he can see, he can do. So engaging him in the surroundings, through that you are actually trying to utilize the vision. It is not always rehabilitation or vision therapy is not always about, or neurooptometry is not always about improving the vision. It's about enhancing the vision and making them functionally activated. So that's our first motto. And then, I repeated it again. So visual barriers. Visual barriers such as visual field. Okay, there is a problem now. The kid I have shown you. Because of the visual field was restricted to her, she was hesitated to look straight. Once the prism kept in front of her, we did not improve her vision, but rather we removed her barrier and now she can see it straight. So this is how always treatment works. Okay, this is not really important. Alright, so we came to the end of this session. We are already running late. I know you all will be like, oh, why is she not leaving now? Okay, so my gratitude is always to my all respected, dignified gurus, my family and my sakhis, my friends. And thank you so much for being such a wonderful team around. I know many of you have slept, I've seen and I've been into that same situation. So I don't blame you, but I wanted to be more engaged. Whatever information extra you get, I can guarantee that I never spoke about anything which is written in textbook today. Whatever I spoke was nowhere written in the textbook. And nowhere you will find it. It's because I experienced this when I went out of books. Books are very limited. It's just for reading and then pass the exam. When you practically go, experience the real world, talk to the patient, understand different diversity of conditions. These all to be needed actually. Yeah. So in that way, I'm so happy because anyway, okay, again, that diagonal one. Yeah, thank you so much. It was really good. I never had big trouble basically coming here after 7 years and dealing the so-called new generation. It was a little nervous for me because I never spoke to kids. This age people. Whenever we have presentation, it will be like in front of all these aged people and it's very boring. So it's first time actually I'm doing, I have fellow students in my institution, so I speak to them like hardly less than 10. So I was a little nervous, but you all made it very comfortable. Thank you so much. It was a great talking to all of you. thank you. So, just one take-home message. That's it. I'm winding it up now. Just whatever. As again, I've told you with the lunch break. Maybe we was talking about it. One day, there is one day you will surprise yourself. Yeah? Promise? Yeah. Thank you so much.
Before ending the session, I would like to call our college Vice Principal Mini Ma'am and the Coordinator of Indian Academy of Optometry, Prabhashini Ma'am, to the dais. This session was so helpful because usually we don't discuss about these topics, especially this cortical visual impairment or vision therapy. So I think this is a great session for not only for students, for us also. And we hope to see you in the future also. And thank you for being here. And so here I'm requesting our Vice Principal Mini Ma'am and the Coordinator Prabhashini Ma'am to hand over the token of love to Arya Ma'am. Please.
എനിക്ക് ഇങ്ങോട്ട് കൊണ്ടുതന്നിട്ടുള്ള ആളാണ്. നമ്മുടെ സ്റ്റുഡൻസിന് അറിയാം. സ്റ്റുഡൻ്റ് ആയിരിക്കുന്ന സമയം തൊട്ട് നമുക്ക് ഒരുപാട് ട്രോഫികൾ നമ്മുടെ സ്ഥാപനത്തിന് വേണ്ടി നേടിത്തന്നിട്ടുള്ള ഒരാളാണ്. അപ്പോൾ ഈ ഒരു മൊമെൻറ്റിൽ ഐ ആം വെരി പ്രൗഡ്. കാരണം അക്കാദമിക്കലി ആയിട്ട് ഉയർച്ചയിൽ വന്നിട്ടുള്ള ഒരു സ്റ്റുഡൻറ്റിന് നമുക്ക് വേണ്ടി, നമ്മുടെ കുട്ടികൾക്ക് വേണ്ടി, അല്ലെങ്കിൽ നമ്മുടെ സ്ഥാപനത്തിന് വേണ്ടി ഒരു ക്ലാസ് എടുത്ത് തന്ന് അവൾക്കൊരു മൊമെൻറ്റോ, ഹരിക്കൊരു മൊമെൻറ്റോ കൊടുക്കാൻ പറ്റുക എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അല്ലേ ഹരിയ, ഇറ്റ്സ് പ്രൗഡ് മൊമെൻറ്റ്. താങ്ക് യു.
Okay, thank you very much, Miss Arya Shekhar, for this presentation, and it was really informative, and thank you so much again.
It was my pleasure.
So we'll wind up the session, and thank you all for being here. Thank you. എക്സ്ക്യൂസ് മീ. സോ നിങ്ങളുടെ സർട്ടിഫിക്കറ്റുകൾ ഇവരെ പ്രൊവൈഡ് ചെയ്യുന്നുണ്ട്. 1 by 1 നിങ്ങൾക്ക് വന്ന് സർട്ടിഫിക്കറ്റ്സ് കളക്ട് ചെയ്യാവുന്നു. താങ്ക് യു. ഓരോരുത്തർ റേഹാൻ സ്റ്റുഡൻസ് പ്ലീസ് വെയിറ്റ്. ഔട്ട്സൈഡേഴ്സ് ആരെങ്കിലും ഒന്ന് പെട്ടെന്ന് കേട്ടോ. ഒരു മിനിറ്റ്. ഈ കോളേജിലെ സ്റ്റുഡൻസ്